Pre-operative preparation of the surgical patients. Our job is to operate. But remember, the good surgeon knows how to operate, the better surgeon knows when to operate, and the best surgeon knows when not to operate. আমার কাছে আজ বিকেলে একটা অ্যাপেন্ডিক্স পেশেন্ট এলো, এই চল এখনই কাটি বেটাকে, কাটলেই পকেটে টাকা ঢুকবে, তাই তো? No. If we run by that principle, we will lose the patient. So the first part of any surgical procedure is gaining absolute trust of the patient and his or her relatives. Am I clear? So, communicate well. Next slide. Communicate well with the patient. Earn his or her trust. Explain each and everything, what you are trying to achieve, what are the potential risks, what are the benefits that you can get from this surgery, and explain it in their own language as far as practicable. Why? Suppose I can't expect a Dehati woman sitting in Jharkhand and explain her in Bangla. Or if I go to Tamil Nadu, I cannot explain a Tamil lady, village, rural lady in Bangla or in English. I have to either by direct in communication or by interpreter. We have to communicate that way. Next, what are the types of surgery? We can broadly classify surgery into 3 groups. One is emergency. What is emergency? Which, if not done as soon as possible, may lead to loss of life or loss of a vital organ. For example, a patient with a bullet injury here hitting the brachial artery. If I don't do anything, this part of the limb will be lost. So, just to save this vital organ, emergency surgery is needed. Am I clear? Urgent surgery. What is urgent surgery? So, no, sorry, let me finish. That means emergency surgery can be broadly classified into 2 groups. Life-saving, vital organ or limb saving. Okay? Any penetrating injury into the mesentery with bleeding. If we don't operate immediately, or a ruptured ectopic pregnancy, if we don't operate immediately, we will lose the patient. So that is life-saving or vital organ or limb saving. That is emergency surgery. Urgent surgery, which if not done as within the next 24 to 48 hours, can lead to grave morbidity or mortality of the patient. For example, a patient of peptic perforation with severe dehydration. What is peptic perforation? Perforation in any part of stomach or duodenum. So it has perforated, given rise to peritonitis, and the patient is having hypovolemia. If we operate the patient without correcting the hypovolemia, the patient don't come out from the operating room. Am I clear? So resuscitate the patient, get his or her vitals stable, then operate. This is urgent operation. That usually the time limit is within 48 hours. Okay? And the third is elective surgery. Suppose I am having a hernia. So I decide, okay, 15th August, 13th to 15th, I will have some holiday, I will operate at that time. So I plan accordingly and go to the surgeon. The surgeon decides, okay, these are the times, these are the way we can operate, we will decide that. That is elective surgery or planned surgery, whatever you call it. Now, what are the aims of surgery? Cure and control of disease is the most important aim. You are having appendicitis, I am doing appendectomy, you are cured of the problem. You are having a hernia, I am doing a hernioplasty, that is getting control. That is part of the problem. Next is prevention of disease. Prevention of disease by surgery. Has anyone heard of Angelina Jolie? BRCA gene positive. These patients have a 90% chance of developing breast cancer. So she did a bilateral mastectomy. For example, patients with hereditary colon cancer syndromes like familial adenomatous polyposis coli, these patients have a 90% chance of developing colon cancer. So protective total colectomy is done in these patients. So these operations are done to prevent a disease. And third is palliative surgery. A patient with giant gastric carcinoma which we cannot resect because it is adhered to the pancreas, adhered to the liver. There is no point in resecting, but the patient is having gastric outlet obstruction, cannot swallow food. So we are doing a palliative gastrojejunostomy so that the patient can eat properly. Remember, everyone has the right to live with dignity and also the right to die with dignity. Am I clear? Now the next topic. So, classify the risk of a surgical patient. In emergency cases, the letter E is used. That is E-surgery. Now, there is a ASAPS status, classification of patients. These are all practically for elective cases, okay? Because there you have the time to prepare a patient. In emergency, you have no option, you have to operate. In urgent also, the time to prepare is very less. But in elective cases, you have the time to prepare a patient for surgery. What is this? ASA is American Society of Anesthesiologists. Physical status, American Society of Anesthesiologists. PS is physical status. Class 1 is normal healthy patient, just like you guys and girls. Class 2 is a patient with a mild systemic disease, just like well-controlled diabetes mellitus. It's a mild systemic disease. With a severe systemic disease, that is angina pectoris, but the patient is having poor effort tolerance. A patient with severe systemic disease that is a constant threat to life. Unstable angina, for example. And last is a moribund patient. He is so ill that he is unlikely to survive without the operation. Okay? And even during operation, the chances of mortality is pretty high. That is ASA class 5. Class 1 and 2 is low risk. Class 3 is intermediate risk. Class 4 and 5 are high risk patients. Now, pre-operative planning. The aim of planning is the best patient outcome. সোজা কথা আমরা বলি পেশেন্ট হেঁটে আসবে হেঁটে বাড়ি যাবে, কারোর ঘাড়ে চেপে যাবে না, তাই তো? তার জন্য what we have to do? Gather and record all relevant information, optimize the condition. আজকে একটা হাইড্রোসেল পেশেন্ট এলো, সুগার 520, আমি অপারেশন করলাম, ডায়াবেটিক সেপ্টিসেমিয়াতে চলে গেল বা ডায়াবেটিক কিটোঅ্যাসিডোসিস হয়ে গেল, পেশেন্ট চলে গেল। সুগারটা নামিয়ে আনো, তারপর করো, control it. Choose the procedure that offers maximum benefit with minimum risk. Number 4 is anticipate and plan for adverse effects. আজকে প্রচন্ড ঝড় বৃষ্টি হচ্ছে, আমি ছাতা নিয়ে বেরোলাম। এত ঝড় বৃষ্টি হচ্ছে, আমার ছাতাটা যথেষ্ট নাও হতে পারে, এই যে আমাকে শেল্টারের ব্যবস্থা রাখতে হতে পারে, আমাকে প্রয়োজনে কোথাও গিয়ে দাঁড়াতে হবে। অ্যান্টিসিপেট ইট, ইউ মে নিড ইট। বা আজকে আকাশটা মেঘলা, ছাতাটা নিয়ে বেরোলাম, ইউ আর অ্যান্টিসিপেটিং দ্যাট দেয়ার মে বি রেইন। বা প্রচন্ড সামার হিট, একটা ছাতা নিয়ে বেরোলাম, সঙ্গে একটা জলের বোতল নিয়ে বেরোলাম, ইউ আর অ্যান্টিসিপেটিং। Similarly, you anticipate that this patient may have. So, without this data, first point, that is gather and record all relevant information, you cannot anticipate it. So, if I don't know the patient is having a, say, severe respiratory distress or having asthma, I won't be prepared with bronchodilators and all other therapies in the post-op. So, that is the importance of gathering the relevant information. Adequate hydration, nutrition and exercise. A lot of mortality in our country is because of poor nutrition, because that builds up body reserve. And remember, obesity is not good nutrition. Malnutrition মানে আমরা কি বুঝি? রোগা টিংটিংয়ে, that is malnutrition, exactly. But this is also malnutrition. Mal means abnormal. Under is abnormal, over is also abnormal. So I am also malnourished. Okay? Now, key topics in past medical history. The most important system, that is cardiovascular system. Take history whether of valvular heart disease, ischemic heart disease, angina or myocardial infarction, hypertension, heart failure or dysrhythmia or arrhythmia, peripheral vascular disease, deep vein thrombosis and pulmonary thromboembolism. Inquire about this during history taking. Next slide. Respiratory system. Inquire about asthma, COPD. By the way, here inquire about personal history. Many patients may not have overt COPD, but chronic smokers or chronic bitter lip chewers may have certain airway problems, respiratory tract infection, cough, cold, all these things. Why cough, cold? Because they can give rise to sudden bronchospasm, which becomes very difficult to treat. Yes? ওটা তো পরে, আমি তো হিস্ট্রি নিচ্ছি, হিস্ট্রি নিয়ে কি করবো? I am taking history, man. তাই না? Gastrointestinal tract, peptic ulcer disease, gastroesophageal reflux disease, liver disease history. Genitourinary tract, renal dysfunction. হঠাৎ renal dysfunction কেন হিস্ট্রি কেন নেবো? আমি একটা থাইরয়েড অপারেশন করবো। Yes, only anesthesia কেন? আমি যে অ্যান্টিবায়োটিকটা দেবো সেটাও তো রেনাল এক্সক্রিশন হবে। ম্যাক্সিমাম কমন তো হচ্ছে সেফালোস্পোরিনস, মোস্ট কমনলি ইউজড। সেফালোস্পোরিন তো বা পেনিসিলিনস, অ্যামোক্সিসিলিন, আমি যাই দিই, they are excreted by kidneys. So we have to কি বলবো, we have to modify the dose accordingly. Neurological system. Epilepsy. What is the importance of epilepsy? Drug interaction with anesthetic agents. Next is CVA, cerebrovascular accident. Ischemic heart disease কেন হয়? Due to atherosclerosis. প্যাথোলজিতে পড়ছিস? atherosclerosis পড়া হয়েছে প্যাথোলজিতে? এখনো সিস্টেমই হয়। Atherosclerosis is a generalized disease where the arteries get thinned. The arteries get thinned. And it is a systemic disease. If the blood arteries of the vein are thin, brain are thin, the heart is also thin. The leg vein arteries are also thin. Psychiatric disorders, cognitive dysfunction and all those things. Endocrine and metabolic disorders. For all practical purpose, India is the diabetes capital of the world. প্রবলেমটা কোথায়? আমার কাছে 3 রকম পেশেন্ট আসতে পারে। ডাক্তারবাবু আমার ডায়াবেটিস আছে, আমি ওষুধ খাই, ভালো আছি, ফাইন। আমি সুগার চেক করে দেখে নিলাম, HbA1c দেখে নিলাম, এর লেভেলস আর নর্মাল, ফাইন। দিস ইজ দ্য ফার্স্ট পার্ট। সেকেন্ড পার্ট হলো, হ্যাঁ ডাক্তারবাবু আমি সব করি কিন্তু আমার সুগারটা বেশি থাকে। অ্যাকচুয়ালি এগুলো দিস আর ফেক। এরা বাড়িতে লোকের সামনে নিয়ম মেনে চলে, বাইরে গিয়ে খায়। যে কোনো নামি মিষ্টির দোকানের বাইরে দেখবি 2-1 পিস এরকম পাবি, লুকিয়ে লুকিয়ে মিষ্টি খাচ্ছে। তার এই কন্ট্রোলটা লাইফ লং মেনটেন করা ইজ ভেরি ডিফিকাল্ট। ওকে, সো পোরলি কন্ট্রোল। থার্ড ইজ নিউলি ডিটেক্টেড। পেশেন্ট এলো তোর কাছে অপারেশন করাতে, তুই একটা সুগার করতে দিলি 325। দ্য প্রবলেম স্টার্টস হিয়ার। এই যে 325 হয়ে আছে, ফাস্টিং সুগার বা পিপিটা 500 হয়ে আছে, এটা কতদিন ধরে আছে কেউ জানে না। It may be for 5 years duration, it may be for 10 years duration, it may be for 6 months duration, no one knows. And no one knows what end organ damage this thing has caused. So you have to be careful, okay? Next is locomotor system. Osteoarthritis, rheumatoid arthritis. Can osteoarthritis can interfere with your positioning of the patient during surgery. Rheumatoid arthritis, particularly of the cervical spine, may make endotracheal intubation much difficult. কারোর বুঝতে অসুবিধা হলে please interrupt, no problem, okay? Next is other disorders. HIV, hepatitis B, C, venereal diseases. Why HIV, hepatitis B and C? দুটো কারণ। One হচ্ছে majority of the patients of these are on antiretroviral. They can give rise to certain problems in the patient. And for your protection, for the protection of the healthcare personnel, okay? Tuberculosis, malignancy, allergies and bleeding disorders. Sexually transmitted diseases are also called venereal diseases. Actually, HIV can be classified, but that is not the major mode of transmission of HIV. Am I clear? Past surgical history. Past surgical history of any operation, type of anesthesia, or any surgical or medical problems which was encountered during that surgery. If yes, how it was managed. Detailed drug history. এটা আবার পরে আসছি ডিটেলসে। Detailed drug history, family history of problems with anesthesia. Am I clear? Now, general survey, thorough clinical examination of the patient. First part, general survey, very important. Number 2 is systemic examination of all systems. Airway assessment. Airway assessment for all practical purpose is done by anesthetist and not by surgeons. Amra kori na, but it should be done preoperatively. Usually done by anesthesiologists. How it is done? It is Samsung and Young modification of Malampati examination. Malampati test grade 1, fauces, pillars, soft palate and uvula all can be seen by just simple mouth opening. Only fauces, soft palate and some part of uvula seen. That is grade 2. Only soft palate seen. Soft palate and hard palate both seen. That is grade 3. You cannot see soft palate without seeing the hard palate. Lastly, only hard palate seen. That is grade 4. Grade 4 patients and grade 3 patients possess difficulty in endotracheal intubation. So you have to be prepared alongly. Now, how do I investigate the patient? Any problem, Sharon? কি? আরেকবার, আচ্ছা দাঁড়া এই রে পরে চলে যাচ্ছে তো আগে এই কি করে? Grade 1, fauces, pillars, soft palate, uvula, মানে এভরিথিং, মুখ খুলে আমি উভুলা অব্দি দেখতে পাচ্ছি পুরোপুরি। পরেরটায় আমি পার্ট অফ উভুলা দেখছি, পুরো উভুলা দেখতে পাচ্ছি না। ম্যালাম্পাটি 2, ম্যালাম্পাটি 3-তে আমি সফট প্যালেট অব্দি দেখতে পাচ্ছি, হার্ড প্যালেট তো তার মানে পাচ্ছি। গ্রেড 4-এ আমি সফট প্যালেটও দেখতে পাচ্ছি না। মানে মোদ্দা কথা বড় করে হা করো, হা করে দেখো। দেখবি ওটিতে গেলে অ্যানাস্থেটিস্টটা ফার্স্টে বলে হা করো, হা করে এটা দেখ। ক্লিয়ার? এবার ইনভেস্টিগেট দ্য পেশেন্ট। জেনারেল ইনভেস্টিগেশনস, কমপ্লিট ব্লাড কাউন্ট, কোয়াগুলেশন প্রোফাইল, ব্লাড গ্রুপিং। তারপর কার্ডিয়াক, চেস্ট এক্সরে, ইসিজি, ইকোকার্ডিওগ্রাফি, এটা হচ্ছে রুটিন। হঠাৎ কার্ডিয়াকের জন্য চেস্ট এক্সরে বলছি কেন, কেউ একটু বোঝাবি? আমি কার্ডিওলজিতে কেন চেস্ট এক্সরে বলছি? অনেক বেশি কঠিন ভেবে ফেলবি, কমন গুলো ভাব। ভালো বলেছিস, বুট শেপেড হার্ট হতে পারে, হাইপারট্রফি, হাইপারটেনসিভ হার্ট। সেকেন্ড হচ্ছে স্ট্রেটেনিং অফ দ্য লেফট বর্ডার অফ হার্ট হয় রিউম্যাটিক হার্ট ডিজিজে। রিউম্যাটিক হার্ট ডিজিজও হয়, যেখানে লেফট এট্রিয়াম বড় হয়, মাইট্রাল স্টেনোসিসে লেফট এট্রিয়ামটা বড় হয়, লেফট ভেন্ট্রিকলটা ছোট থাকে। আচ্ছা, এবার আমার চেস্ট এক্সরে, ইসিজি আর ইকো ফাইন্ডিং এর উপর ডিপেন্ড করবে আমি ফার্দার ইনভেস্টিগেট করব কেন, করব কি করব না, এগুলো গন্ডগোল। মোদ্দা কথা মনে রাখবি, ইসিজি শোজ দ্য ইলেকট্রিক্যাল অ্যাক্টিভিটি অফ দ্য হার্ট, ইকো শোজ দ্য মেকানিক্যাল অ্যাক্টিভিটি অফ দ্য হার্ট। এই দুটো ফাইন্ডিং এর উপরে ফার্দার ইনভেস্টিগেশন। সেগুলোর মধ্যে ট্রেডমিল আছে, হল্টার আছে, স্ট্রেস ইসিজি আছে, স্ট্রেস ইকো আছে, করোনারি অ্যাঞ্জিওগ্রাম আছে। এগুলো আমি সবকটা রুটিন পেশেন্টকে করতে দেবো না, আমি করতে দেবো বেসড অন ফাইন্ডিং অফ দ্য প্রিভিয়াস এক্সামিনেশনস। রেসপিরেটরি সিস্টেম, দ্য ইনভেস্টিগেশন ইজ চেস্ট এক্সরে। Further tests like lung function test depends when needed. Routine নয়, ঠিক আছে? Clear? Investigations এ GIT তে আমি কি করব? Liver function test again to know the metabolic pathway. আমার ড্রাগ ডোজ মডিফাই করতে হবে কিনা। Renal function test same. Electrolytes করতে হবে, particularly in emergency and urgent cases. Clear? কেন? ইমার্জেন্সি হচ্ছে অ্যাকিউট ইলনেসে অনেক ক্ষেত্রে ডিসইলেক্ট্রোলাইটেমিয়া হয়, ব্লাড লস বেশি হলে, ফ্লুইড লস বেশি হলে পটাশিয়াম সোডিয়াম ভ্যালু গন্ডগোল হয়ে যায়। এবিজি, আর্টেরিয়াল ব্লাড গ্যাস ইন এভরি ক্রিটিক্যালি ইল পেশেন্ট। এন্ডোক্রিন সিস্টেম কি কি? ফাস্টিং পিবি সুগার, HbA1c, ইউরিন ফর সুগার, প্রোটিন অ্যান্ড কিটোন বডিজ, এগুলো রুটিন টেস্ট। আর থাইরয়েড প্রোফাইল T3, T4, TSH করতে হবে। ভাইরাল মার্কারস, HIV, হেপাটাইটিস B, C। এবার তাহলে আমার কাজ কি হলো? একটু আগে আমি বলছিলাম ASA PS1, তার সঙ্গে এটার মিল পাবি। আমি এতক্ষণ ধরে হিস্ট্রি, ক্লিনিক্যাল এক্সামিনেশন, ইনভেস্টিগেশন করে আমি পেশেন্টকে এই জায়গায় নিয়ে আসতে পেরেছি যে আমি যা যা আছে সেটাকে আমি ক্লাসিফাই করছি। একটা হচ্ছে নো ডিজিজ, পারফেক্টলি হেলদি পেশেন্ট, ফাইন, হ্যাভিং এ ট্রিটেবল অ্যান্ড কিউরেবল ডিজিজ। শ্বাসকষ্ট হচ্ছে, রেসপিরেটরি ট্র্যাক্ট ইনফেকশন, দুটো অ্যান্টিবায়োটিকের কোর্স খাওয়ালাম, কি একটা কি দুটো অ্যান্টিবায়োটিকের কোর্স খাওয়ালাম, ইনফেকশন সেরে গেল, রেসপিরেটরি ফাংশন ইমপ্রুভ করলো, অপারেশন করলাম। হ্যাভিং এ ডিজিজ that is treatable and controllable but not curable. Example, hypertension. Huh? Leukemia is not in this group. Leukemia কে এখানে ফেলা মুশকিল। লিউকেমিয়া তার পরেরটা, লিউকেমিয়া তার পরেরটা, কমনটা আগে ভাব, তোকে বারবার বলছি। হাইপারটেনশন, পেশেন্টটা তোর কাছে এলো 180/120 বিপি নিয়ে, অপারেশন করতে যাবি, যখনই তুই এই টিউব পড়াতে যাবি বিপি শুট করবে, 260 হবে, একটা ইন্টারসেরিব্রাল হেমারেজ হয়ে গেল, পেশেন্টের অপারেশন হলো, পেশেন্টটা প্যারালাইজড হয়ে বাড়ি ফিরলো, লাভ কি? হ্যাভিং এ ডিজিজ দ্যাট ইজ ট্রিটেবল অ্যান্ড কন্ট্রোলেবল বাট নট কিউরেবল, এটা গেল নাম্বার 3। নাম্বার 4, হ্যাভিং এ ডিজিজ উইচ ইজ ভেরি ডিফিকাল্ট টু কন্ট্রোল, যেটাও এক্সাম্পল দিল একটা লিউকেমিয়া অথবা রিট্রাক্টেবল হাইপারটেনশন। ডিজিজ ইজ সো সিভিয়ার দ্যাট দেয়ার ইজ হাই চান্স অফ মর্টালিটি। সিভিয়ার ইসকেমিক হার্ট ডিজিজ, এই পেশেন্টের পেপটিক পারফোরেশন হয়েছে, আমাকে অপারেশন করতেই হবে। প্রথম কথা, PS4-5 আমি পেশেন্টটাকে এই 5টা প্রশ্ন করতে পারছি। ইমার্জেন্সি পেশেন্ট ক্যান বি অফ 2 টাইপস, কনশাস, আনকনশাস। ঠিক আছে? ইমার্জেন্সি পেশেন্ট ক্যান বি অফ 2 টাইপস। বস দাঁড়িয়ে থাকার দরকার নেই। কনশাস, আনকনশাস। If the patient is conscious, take a 5-minute history. Take a 5-minute history. Get yourself familiarized to the patient. তুই যত ইমার্জেন্সি হোক, যতক্ষণ না ব্লাড আসছে তুই করতে পারছিস না, তোকে ব্লাডটা তো অ্যারেঞ্জ করতে হবে। তুই ততক্ষণ একটা এবিজি কর, 2 মিনিটের রেজাল্ট এসে যাবে। একটা হিমোগ্লোবিন, ইউরিয়া, ক্রিয়েটিনিন, সোডিয়াম, পটাশিয়াম করে নে, 5 মিনিটের রেজাল্ট আসবে। আজকাল অটো অ্যানালাইজারের যুগ, ব্লাডটা ফেল, 5 মিনিটের মধ্যে রেজাল্ট চলে আসবে। কথাটা বোঝাতে পারছি? Now you know what to expect. এবার তুই এক্সপেক্ট করছিস ব্লাড লস আছে, যেমন রাপচারেক্টমি। Don't wait till the blood comes, because কল খোলা, জল ভরে লাভ নেই, ট্যাঙ্ক ভরে লাভ নেই, কলটা তো খোলা। আমাকে আগে ব্লিডিংটা থামাতে হবে, তারপর আমার ব্লাডটা দরকার। ব্লাড আস্তে আস্তে আমি ব্লিডিংটা থামিয়ে দিই। বুঝাতে পারলাম? Am I clear? Next is disease is so, এই গ্রুপটার পরে নেক্সট। তাহলে কোন কোন পেশেন্টের হাই রিস্ক অফ মরবিডিটি আর মর্টালিটি আছে, তাহলে আমাকে সেটাকে এবার ওখানে ফেলে দিই, আগেরটাকে এবার একটু ইলাবোরেট করি। Number 1, any previous illness like myocardial infarction, CVA, COPD, asthma. Late stage vascular disease involving aorta, মানে generalized atherosclerosis, aortic aneurysms. Limited physiological reserve, particularly in elderly. Extensive surgery, বিরাট বড় অপারেশন হচ্ছে for carcinoma. কেন? ক্যান্সার পেশেন্টস অলরেডি ডেবিলিটেটেড থাকে। ক্লিয়ার? acute abdominal catastrophe with hemodynamic instability. তো আমি তোকে 3টে ঘুষি মারলাম, তো লিভার রাপচার করলো, স্প্লিন রাপচার করলো, ম্যাসিভ ব্লাড লস হয়ে গেল, তো তোর পুরো সিস্টেম ঘেটে গেল। ইজ ম্যাসিভ ব্লাড লস, ব্র্যাকেটে দিয়ে দিয়েছি, more than 40% of blood volume loss. হ্যাঁ, তারপর সেপ্টিসেমিয়া, পজিটিভ ব্লাড কালচার অর নন ইনফেক্টিভ ফোকাই, অ্যাকিউট রেনাল ফেইলিয়ার। অ্যাকিউট রেনাল ফেইলিয়ার কেন হয়? মোস্ট কমন কজ হচ্ছে হাইপোভলিমিয়া, সেখান থেকে অ্যাকিউট টিউবুলার নেক্রোসিস হয়, সেখান থেকে অ্যাকিউট রেনাল ফেইলিয়ার হয়। Usually it is a totally reversible condition. Pressure of oxygen in peripheral blood is low. FiO2 is more than 40%. Mechanical ventilation for more than 48 hours. These patients have a higher chance of severe morbidity and mortality. So এটা একটা generalized discussion হলো। তাহলে এবার স্পেসিফিক্স একটু আসা যাক। সত্যি কথা বলতে কি, প্রত্যেকটা ডিজিজ নিয়ে একাধিক ক্লাস চলতে পারে। সো একটা কি দুটো ক্লাসের মধ্যে প্রত্যেকটা ডিজিজ তো ডিসকাস করা সম্ভব না। আর ফ্র্যাঙ্কলি আই ডোন্ট নো ইট। I don't know the recent advances of myocardial infarction management, or I don't know the recent advances of many other diseases. So, cardiovascular system এ আমি কখন কার্ডিওলজিস্টের কাছে পাঠাবো? নেক্সট স্লাইড। কিছু বলছিস? নেক্সট স্লাইড। এসে গেছে। Cardiovascular referral is a must if there is symptoms of heart disease. Abnormal sound on auscultation or deranged ECG or deranged echocardiogram. Ischemic heart disease. এবার তারপরেই তো লিখেছি, invasive or non-invasive intervention of ischemic heart disease as per advice of cardiologist. I am not qualified enough to advise coronary angiography in a patient. That advice must come from a cardiologist. তাই তো? After proven myocardial infarction, elective surgery should be postponed for 6 months, ideally. But at least 3 months is mandatory. But here comes the problem. আজকে হার্ট অ্যাটাক হলো, 2 মাস পরে জানা গেল পেশেন্টের কোলন ক্যান্সারও আছে। ক্যান্সার ট্রিটমেন্টে তো বলাই হয়, from 7 days of diagnosis, the first part of treatment must be complete. হলো 1.5 মাসের মাথায় তার ধরা পড়লো তার কোলন ক্যান্সারও আছে, তখন আমাকে রিস্ক নিয়ে করতে হবে, knowing and the chances of mortality and morbidity will be pretty high. বিপি, একটু আগে হাইপারটেনশন নিয়ে কথা হচ্ছিল, আইডিয়াল বিপি 140/90, সবাই জানে। নেক্সট স্লাইড। মিনিমাম রিকোয়ারমেন্ট হচ্ছে 160/100, আইডিয়াল 140/90, মিনিমাম 160/100। আর কি, if you have started a new antihypertensive, give at least 2 weeks time. এবার অ্যান্টিহাইপারটেনসিভ ক্লাসিফিকেশন পড়েছিস ফার্মাকোলজিতে, ড্রাগ গ্রুপসের, ডাইউরেটিক্স, বিটা ব্লকার্স, আলফা ব্লকার্স, ক্যালসিয়াম চ্যানেল ব্লকার্স পড়েছিস? পড়া হয়েছে? কেন? অ্যাটেনোলল, মেটোপ্রোলল, এসমোলল, ল্যাবেটালল। Now labetalol is alpha and beta both. Labetalol and dilevolol is both. Most commonly used is atenolol, metoprolol, bisoprolol, esmolol. এই চারটা হচ্ছে most commonly used. Beta blockers should be continued. May consider holding ACE inhibitors like captopril, enalapril, ramipril. যত প্রিল আছে ঢুকিয়ে দাও। আর angiotensin blocker, olmesartan, telmisartan, losartan, ঠিক আছে? ক্লিয়ার? মনিটর সিরাম পটাশিয়াম লেভেল ইফ অন ডাইউরেটিক্স। কেন? ফুরোসেমাইড, টরসেমাইড, দিস কল হাইপোক্যালিমিয়া, এই পটাশিয়াম লেভেল মনিটর করতে হবে। আর যদি পটাশিয়াম স্পেয়ারিং ডাইউরেটিক লাইক স্পাইরোনোল্যাকটোন, অ্যামিওডার, আরেকটা ছিল ট্রামসিনোলন, স্টেরয়েড, যারা ওটা ভুলে গেছি, দেখতে হবে, ছেড়ে দে। পটাশিয়াম স্পেয়ারিং আমার একটাই মনে আছে, স্পাইরোনোল্যাকটোন। দিস ক্যান কজ হাইপারক্যালিমিয়া। হ্যাঁ, ইয়েস, তাই বলেছি, আমি প্রোপানল শুনেছি। সরি 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 দিস ক্যান কজ হাইপারক্যালিমিয়া, সো ইউ হ্যাভ টু মনিটর। হাইপারক্যালিমিয়া হলে কি করে, কি ট্রিটমেন্ট দেয়? হ্যাঁ, ইমিডিয়েট যদি কন্ট্রোল করতে হয়, দেওয়া হয় গ্লুকোজ প্লাস ইনসুলিন। গ্লুকোজ প্লাস ইনসুলিন, ইনসুলিন ইন্ট্রাভাস্কুলার পটাশিয়ামটাকে ইন্ট্রাসেলুলার করে দেয়, সিরাম পটাশিয়াম কমে যায়। বোঝাতে পারলাম? আর সিভিয়ার হাইপারক্যালেমিয়া হলে ইমার্জেন্সি ডায়ালিসিসও দিতে হতে পারে। এরপর হচ্ছে ইমপ্ল্যান্টেড পেসমেকার অর ইন্ট্রাকার্ডিয়াক ডিফিব্রিলেটর যার রয়েছে যে পেশেন্টের। অপারেশন করতে গেলে তো ডায়াথার্মি করব। মনোপোলার ডায়াথার্মিকে ওই মনোপোলার ডায়াথার্মিতে কি হয়, এনি আইডিয়া? ডায়াথার্মি আর বাইপোলার ডায়াথার্মি দুটো জিনিস আছে। কি হয় মনোপোলার ডায়াথার্মি? ওটিতে কে কে গেছিস? গেছিস? ডায়াথার্মি দেখেছিস? ডায়াথার্মি হচ্ছে একটা মেশিন যেটা দিয়ে কারেন্ট পাস করছে, ব্লাডকে কোয়াগুলেট করা হয়, ডায়াথার্মি। ঠিক আছে? বা ওটাকে অনেকে বলে ইলেকট্রোকটারি, ইলেকট্রোকটারি বা ডায়াথার্মি। ঠিক আছে? এটা দুটো জিনিস। যে কোনো ইলেকট্রিসিটির ফার্স্ট কথা হচ্ছে সার্কিট মাস্ট বি কমপ্লিট। মানে আমি যদি এই কাঠের বেঞ্চে দাঁড়িয়ে লাইভ ওয়্যারে টাচ করি আমার কিছু হবে না, কারণ দিস ইজ নট কন্ডাক্টিং ইলেকট্রিসিটি, আমার বডি দিয়ে কারেন্টটা পাস করছে না, সার্কিট কমপ্লিট হচ্ছে না। যে মোমেন্টে তুই মাটিতে দাঁড়িয়ে আমাকে টাচ করবি, তুইও গেলি আমিও গেলাম, সার্কিটটা কমপ্লিট হয়ে মাটিতে গেল, কারেন্ট পুরো পাস করলো, ফিনিশ। কথাটা বোঝাতে পারছি? মনোপোলার ডায়াথার্মি সার্কিটটা হচ্ছে এইটা, ধর পেশেন্ট শুয়ে আছে, এর পায়ের কাছে একটা বডি প্লেট আছে, এবার তার দিয়ে কারেন্টটা আসছে, সার্জারির যন্ত্র দিয়ে পেশেন্টের বডিতে ঢুকছে, এই বডি প্লেট দিয়ে কারেন্টটা আবার মেশিনে ফেরত যাচ্ছে। বোঝাতে পারলাম? তার মানে পেশেন্টের বডি দিয়ে কারেন্টটা পাস করছে। এবার যে পেশেন্টের পেসমেকার বসানো আছে তার পেসমেকারের ওই পাশ দিয়েও তো কারেন্ট যাচ্ছে। পেসমেকার ইজ নাথিং বাট ইলেকট্রিক্যাল ইম্পালস জেনারেটর। সে তখন ওটাকে ভেন্ট্রিকুলার ফিব্রিলেশন হিসেবে ডিল করবে, লাফালাফি শুরু করবে, গন্ডগোল করবে, প্লাস পেসমেকারের সার্কিট ড্যামেজ হতে পারে। আর যদি ইন্ট্রাকার্ডিয়াক ডিফিব্রিলেটর থাকে, ডিফিব্রিলেটরের কাজ কি? ভেন্ট্রিকুলার ট্যাকিকার্ডিয়া দেখলে ও শক মারতে শুরু করবে, বা ওটার জন্য থামাবার ব্যবস্থা নেবে। হচ্ছে তো একটা ডায়াথার্মিক কারেন্ট পাস, এদিকে ওটাকে রিড করছে ভেন্ট্রিকুলার ফিব্রিলেশন, তাহলে আমাকে কার্ডিওভার্সন আর ওভারপেস মোডটাকে পেসমেকারে অফ করে দিতে হবে। কথাটা বোঝা গেল? এই প্রিপারেশনটা নিতে হবে। কাজেই পেসমেকার আছে কি নেই এটা জানতে হবে। নেক্সট আরেকটা জিনিস, হার্ট ব্লক। যে সমস্ত পেশেন্টের সিমটোম্যাটিক হার্ট ব্লক রয়েছে অথবা এসিমটোম্যাটিক সেকেন্ড ডিগ্রি আর থার্ড ডিগ্রি হার্ট ব্লক রয়েছে, ফিজিওলজিতে পড়েছিস, কমপ্লিট হার্ট ব্লক, ফার্স্ট ডিগ্রি, রাইট অ্যাট্রিয়াল হেভি ব্লক, লেফট অ্যাট্রিয়াল হেভি ব্লক, ফিজিওলজিতে পড়েছিস? পড়েছিস? সেই সমস্ত পেশেন্টের আইদার টেম্পোরারি পেসমেকিং অর পার্মানেন্ট পেসমেকিং ডিপেন্ডিং অন দ্য নিড করে নিতে হবে। ক্লিয়ার? এবার হচ্ছে স্পেসিফিক্স। পেশেন্ট অন অ্যান্টিকোয়াগুলেন্ট অর অ্যান্টিপ্লেটলেট থেরাপি। মোস্ট কমনলি ইউজড এজেন্ট aspirin, clopidogrel or warfarin. Pre-operative INR must be less than 1.5. প্রথম টাইম করে INR দেখা হয়, that must be less than 1.5. তার বেশি হলে you are medico-legally liable. তার বেশি INR এ অপারেশন করলি, প্রচন্ড ব্লিডিং হয়ে মরে গেল, পার্টি তোকে কোর্টে নিয়ে গেলে তোর হাতে হাত করা পড়বেই। ক্লিয়ার? Clopidogrel and or warfarin must be stopped 5 days prior to surgery. Otherwise, the patient will bleed to death. Clear? আচ্ছা, নিউয়ার অ্যান্টিকোয়াগুলেন্টস প্রচুর এসছে। সত্যি কথা বলতে কি এগুলো আমি জীবনে ইউজ করিনি, আমার লাগে না ইউজ করতে। ড্যাবিগ্যাট্রান, রিভারক্সাব্যান, এপিক্সাব্যান, এডক্সাব্যান, এগুলোর বেশিরভাগের নাম আমি কোভিডের সময় জেনেছি। কোভিডের সময় কিছু কিছু নাম জেগে নিচ্ছি। আমি সত্যি কথা বলছি, এগুলোর নামও জানতাম না আমি, অনেস্টলি স্পিকিং। কারণ আমি 95 সালে যখন ফার্মাকোলজি পড়েছি, তখন এই ওষুধগুলোর নাম পৃথিবীতে কেউ জানতো না। এদের মেকানিজম অফ অ্যাকশন আই ডোন্ট নো, ডোন্ট আস্ক মি। আমি ওষুধগুলোর নাম জানি, হয়তো বললাম আমি এগুলোর নামই শুনিনি, কোভিডের আগে নামই শুনিনি। কোভিডের সময় একজনের প্রেসক্রিপশন দেখেছিলাম কোভিড সার্ভাইভারের, তাতে এটা দেখার পরেই গুগল করেছিলাম কি জিনিস এটা, অনেস্টলি স্পিকিং। আর অ্যান্টিকোয়াগুলেশন থেরাপি কিছু কিছু পেশেন্টের মাস্ট, যেমন এট্রিয়াল ফিব্রিলেশন যার আছে, তাহলে আমি কি করব? ওরা অ্যান্টিকোয়াগুলেন্ট তো বন্ধ করে দিয়েছি, তাহলে আমাকে হেপারিন বা লো মলিকুলার ওয়েট হেপারিন দিয়ে রাখতে হবে। কেন আমি হেপারিন দেবো? তাহলে ওয়ারফারিনও তো অ্যান্টিকোয়াগুলেন্ট, ওয়ারফারিন দিলাম না, হেপারিন দিলাম কেন? কেন হলো না? কারণ হেপারিনের স্পেসিফিক অ্যান্টিডোট আছে, প্রোটামিন সালফেট আছে। তো অপারেশনের ঠিক শুরুতে আমি হেপারিনটাকে প্রোটামিন দিয়ে নিউট্রালাইজ করে আমি অপারেশনটা করে আবার হেপারিন চালু করে দিতে পারছি। ওয়ারফারিনের প্রবলেমটা কি? আমার স্পেসিফিক অ্যান্টিডোট নেই, কাজে ইন্ট্রাঅপারেটিভ ব্লিডিং আমি বন্ধ করতে পারবো না। ক্লোপিডোগ্রামের স্পেসিফিক অ্যান্টিডোট নেই, আমি ব্লিডিং বন্ধ করতে পারবো না। প্লাস আমি বন্ধ করার পর অপারেশনের পর ইমিডিয়েটলি চালু করলে ওর অ্যাকশন হতে 3-4 দিন সময় লাগবে। এই সময়টা ব্রিজিং হেপারিন বা লো মলিকুলার ওয়েট হেপারিন দিলাম। আমি হেপারিন চালু করলাম, অপারেশনের ঠিক মুখে আমি প্রোটামিন দিয়ে দিলাম, হেপারিন নিউট্রালাইজড, ব্লিডিং কন্ট্রোল, অপারেশন ডান, পোস্ট হেপারিন চালু। পরের 2 দিন পর থেকে ওয়ারফারিন বা ক্লোপিডোগ্রাল চালু করে দিলাম, আস্তে আস্তে লেট দেম টেক দেয়ার ফুল অ্যাকশন, আমি হেপারিনটা উইথড্র করে নিলাম। এম আই ক্লিয়ার? বললাম অ্যান্টিকোয়াগুলেশন ট্রিটমেন্ট নিয়ে আমাকে অ্যান্টিকোয়াগুলেশন ওরাল মেডিকেশন বন্ধ করতে হবে। ওয়ারফার অ্যাসপিরিন নিয়ে এখন বলছে বন্ধ করার দরকার নেই, তবু অন দ্য সেফ সাইড আমি ইউজুয়ালি আমার পার্সোনাল প্র্যাকটিসে আমি 4-5 দিন আগে বন্ধ করে দিই। ক্লোপিডোগ্রাল, সায়ন ওদের সঙ্গে কথা বলতে ছিল, বাইরে গিয়ে কথা বল, নো প্রবলেম, আই হ্যাভ নো প্রবলেম। আমার যদি একজনও থাকে আমি তার জন্য আসতে পারি, ঠিক আছে? এরপর হচ্ছে স্পেসিফিক প্রবলেমস এ নেক্সট, ব্লাড ট্রান্সফিউশন, correction of anemia prior to elective surgery. That is mandatory. Minimum requirement 10. এরপরে স্লাইড। টার্গেট হিমোগ্লোবিন prior to elective surgery is 10. আবার বলছি ইলেকটিভ। কেন? যে রাপচার একটোপিক সমানে ব্লিড করছে তার পেটে তখন হিমোগ্লোবিন 5, এবার একে 10-এ তুলে ব্লিডিং বাঁচবে না। Vitamin supplements should be given in every anemic patient. Make no mistake, but remember, use folic acid with caution in cancer patients. Then, if needed, blood transfusion prior to surgery. আরেকটা কথা আজকাল খুব চলে, autologous blood donation. Do you know what is it? নিজের ব্লাড অপারেশনের 3 সপ্তাহ আগে নিজের ব্লাড ডোনেট করে এলো, সেটা স্টোর রইলো, ওই ব্লাডটা ওই 2-3 সপ্তাহের মধ্যে রিপ্লেনিশ হয়ে যাবে বডিতে, অপারেশন চলাকালীন বা অপারেশনের পর সেই ব্লাডটাই ট্রান্সফিউজ হলো। আইডিয়ালি ট্রান্সফিউজ 48 আওয়ার্স বিফোর সার্জারি। কেন? হঠাৎ 48 ঘন্টা আগে দেওয়া সবচেয়ে ভালো। কেন ইলেকটিভ সার্জারিতে? অক্সিজেন ক্যারিং ক্যাপাসিটি ডেভেলপ করতে ইট টেক্স 24 to 48 আওয়ার্স, তাই আইডিয়ালি। ঠিক আছে? ইমার্জেন্সি হলে দিতে হবে। আমি ধর একটা পেশেন্টের অপারেশন করতে গিয়ে এক্সপেক্ট করি ব্লিডিং হবে, ব্লাড নিয়ে নাবিনি, পেশেন্টটা এমনি ঠিক ছিল কিন্তু কোনো কারণে একটু বেশি ব্লিড করলো, তখন আমাকে ব্লাডটা দিতে হবে। তখন কি আর 48 ঘন্টা ওয়েট করে লাভ আছে? যা হয় তাতেই লাভ, তাই তো? নেক্সট, রেসপিরেটরি সিস্টেম। রেসপিরেটরিতে পেশেন্ট ইজ হাই রিস্ক ইফ the patient is on oral steroids, FiO2 is less than FeV1 is less than 30% of the predicted value adjusted for height, age, height and weight. PaCO2 is more than 6 kilopascal. Stop smoking. Amar bipod ache. Will, huh? Regular inhalers to continue. Regional anesthesia and less invasive surgical methods to be considered. Respiratory system next. Next slide. Breathing exercises like incentive spirometry. দেখেছিস? Incentive spirometry দেখেছিস? হ্যাঁ? Incentive spirometry এরকম বলের মতো থাকে টানে।
Is the cerebral injury. As I said, as per the meningeal layers, head injury are really intracranial injury are classified. Head injuries are many, extracranials, cranials, intracranials. Now actually, in my class, my concluding class, the head injury, the cerebral injury. Cerebral injury, yes, whatever happens, the ultimate effect is on the cerebrum. That means that may be hemorrhage, EDH, SDH, subdural hemorrhage, extradural hemorrhage, or subarachnoid hemorrhage, but effect is on cerebrum. That means that is mainly the pressure effect, or SOL type, that means space occupying lesion type, that is most predominant in case of the EDH, not SDH, because of the area it can spread over the intracranial space. So that's why cerebral injury is the ultimate. So in that case, if the cerebrum is affected, so injury, effect of the injury is immediate. So again, remember these things. So first of these, cerebral injury, how it happens. A distinct classification is this concussion. It is a very particular type of cerebral injury. Why it is important? But there is no anatomical or pathological changes occurs, but the effect is severe sometimes, particularly concussion effect is the unconsciousness. So this is the things, what is the concussion, the definition is important. Not that things unconsciousness is important, because concussion effect is different from the other effect, other cerebral injury effect. Why? Just from the definition is thing. That means the state of temporary, mind it, the first keyword, again all the injuries, keywords are important. What actually describes the importance of the injury. Here keyword is temporary unconsciousness. That means if it is not temporary, if it is continuous over the others, that will not be termed as concussion. Concussion is always temporary, particularly as it happens in case of the lucid interval. That is, first unconsciousness was due to the effect of the concussion. So this important concussion definition is important. Remember, the state of temporary unconsciousness here, this particularly this temporary unconsciousness, always remember, partial or complete paralysis of, again these things, due to the partial or complete paralysis of cerebral function. Unconsciousness is due to the loss of functions. Again, no anatomical or pathological, even after these things, the extensive pathological study has been done, but nothing has been found. So that is the peculiarity of the unconsciousness as a state of head injury. And due to head injury, comes on immediately, again another keyword is comes on immediately after injury, another keyword, temporary unconsciousness, and comes on immediately after the head injury. Once after the impact, whatever is the acceleration, deceleration, anything, immediately after the impact. So naturally these things is always followed by amnesia, loss of memory. That means we integrate, মানে আগে যেতে পারে, retrogrades. So probably it is a very pet actually topics in the movie makings. The loss of amnesia, forgets, and ultimately he becomes fugitive. Naturally, means actually wandering, lunatic type actually here and there. After some time, probably again regain consciousness and memory and come back home, or maybe sometimes some other things. We may do some crime also. So here, with full neurological recovery, usually within 6 hours. Here, all these key words, unconsciousness. Again, remember, this consciousness is a really a peculiar thing where even after the head injury, because this consciousness cannot be detected afterwards, after death or anything, by any study, like CT, MRI, whatever it may be, by any way it cannot be detected. So naturally, that is the things, it is the totally medical explanations to the code of things, because people can do some crimes, people can do something, some happens, and during this period of these times, that means the unconsciousness, consciousness, unconsciousness, because there is no pathological, anatomical or any change, only the functional change. But thing is this, again, report, the temporary unconsciousness comes on immediately after injury, 2 মিনিট 4 মিনিট 6 মিনিট পরে হবে তা নয়, ইমিডিয়েটলি সঙ্গে সঙ্গে, যেটা হচ্ছে ইমিডিয়েটলি আনকনসিয়াসনেস। দেন with full neurological recovery, if it comes after 6 hours, generally within 6 hours, after 6 years, that is a different DAH, another actually terms diffuse axonal injury, DI, or like this thing term, that is not actually the concussion. So this is very important, concussion, legally it is very important, medically it is very important. Recovery if after 6 hours, but before 24 hours, because this is the very important informations, medical legally is very important, and the doctor must have these informations to explain, particularly if any crimes or anything happens, these things, the causations of the particularly the inactions or actions. So naturally this thing, information is important. Time, 6 hours, 24 hours, DAI, all these things important, because it is frequently comes as MCQ. Contusions, the concussions, another thing is contusion. Contusion is really anatomical injury. That means some anatomical change, pathological changes occurs to the brain or cerebrum. So contusions, that is these things, probably in injury, you know these things. Contusion is the bruise. Other cases, the other name of the bruise. So bruise, contusions, there is hemorrhage. There is hemorrhage inside that. And along with these things, there may be lacerations. That means there is a lacerations of the brain tissue. Particularly, you know these things, cerebrums, outside some layers is the gray matter. That is the gray matter. That is very important. Gray matters. So naturally, if that injury occurs to the gray matters, so naturally there are functional changes, not particularly pathological changes occurs, very important changes to the brain function occurs there. So contusions, injury to the superficial layer of brains. Again, these things, contusions, generally superficial layer of the brain, usually at the crest of convolutions. Crest means, you know these things, there is convolutions, actually anatomical. Actually what happens these things, the gray matters, the area is very large. So to accommodate inside our brain, that's why there is a lot of gyrus and sulcus. So there, because of these waves, the gray matter can spread over these things and the increase the surface area. So many amounts of the brain cells, particularly the gray cells, actually can be accommodated within the brains because of these things, convolutions, gyrus, sulcus. You see, again remember this thing. Again, everything, whatever anatomically occurs or changes occurs in the brain has got some natural actions. And why that occurs? Because evolutionary changes occurs. Initially, it was not that convolutions, gyrus and sulcus was not that prominent. Gradually, it becomes prominent with the growth. So that is very important. Gyrus and sulcus and the gray matters, they spread over the gyrus, and the injury occurs on the particularly crests. Crest means actually, if you see this, so naturally, as you see these things, as always these things, gyrus, sulcus. So these are the actually crests, lights and these things. So gray matters, and then white matters, then other tissue is mainly white matters. So when generally damage, contusions or changes occurs there of the crests, because it's convolutions, particularly this sulcus, it cannot, but it had got another peculiarity, because what is, I just think, because what I am going to explain you these things, particularly how the croup and contractile injury, particularly these things occur, particularly the brain. Anyway, first two things, how the brain injury, these two figures, I'll explain later. Here, the brain injury, the different types, as is classified, penetrating, non-penetrating injuries. This is actually, you cannot understand all these things ultimately unless you know these things. The brain high brain injury, particularly the gunshot injury, brain injury occurs peculiar types, and another thing is different. That actually what is this thing, coup and contract. It is very important short note. And peculiar injury occurs only to the brain. And as I said earlier at the beginning of my class, acceleration, deceleration injury. Acceleration, deceleration injury, whenever anybody, it is a law of inertia, as you learned in the physics. Whenever rest means everything rest, whenever moves, everything moves, but again comes in rest. Not all parts comes at rest simultaneously. There is some change. That happens. As I said these things, what is coup and contra coup injury? You see, that is a very peculiar acceleration, deceleration injury or direct hit. তাহলে কি হবে? ব্রেনে যদি ডাইরেক্ট আমি হেডে ইনজুরি করি সেটাও হতে পারে, আর acceleration, that peculiar injury, that occurs only to the brain. Why that occurs and what is coup injury and contra coup injury? You see these things. You see, brain is movable inside the skull. There is space all around. So, suppose I am not going to acceleration, deceleration. There is a direct trauma to the brain. Direct trauma to the brain on the frontal side. So, what happens as the law of inertia? The skull moves first. The brain inside is loose. The brain will not move. So, in that case, what happens is, so naturally in that case, as the skull moves backward, there will be a gap. And inside the brain, again, following the law of inertia, brain rests inside the skull. What happens in this thing? Skull directly hits the brain on the frontal lobe because these things. Again, because why these things? This brain lags behind. Skull moves backwards, but brain lags behind because it is inside the loose. So what happens? This skull will strike the brain. So injury occurs. It is called coup injury. It is called coup injury. So what happens? These things first actually there will be contusions or all these things. The brain tissue is very, very soft. It's non-compressible. So naturally, if any strike that will definitely damage the brain matters, particularly the gray matters and other area. So this is called the strike point. Again, the same things, that is coupement. That means at the site of trauma is very important. This dynamics. Again, dynamics of the head injury is very important. Again, another dynamics, probably the ballistics. The head dynamics is very important, particularly physics knowledge, inertia, how it moves. Now you see these things. What are these things? Once the skull moves backward, there will be the gap, the occipital side increases. So what happens to these things? Because of this gap increases, because there are two theories are there. One of these things. One important and very common theory is this. Because of the inertia, moves backwards. So what happened? The gap increases, there will be a vacuum created. So because of this vacuum, again, so there will be a traction. Again, whatever this thing, vacuum means negative pressures, there is just tractions on the brain. And now, after hitting these things, brain next moves backward. So next step, after that things, this gap increases, so brain next moves backward and that hits the skull in the thing. So that is contracoup injury. That means opposite to the skull, that is opposite to the injury, that is called contracoup injury. So that things, this mechanism of coup and contra coup injury is very important. So where the contra coup injury is very, very common, I will show you in the figures. So this is the coup and mechanism of the coup and contra coup injury. For these things, because particularly the law of inertia, all these things, skull and brain, the two things does not move simultaneously. So naturally, what happens in this case? Suppose a person is moving, you are in the car, in a high velocity you are moving. So your whole body is moving, head is also moving, but suddenly it comes to the rest. So either not the brain, the head is not hitting the dashboard, but still it comes because of this belt and other things, it comes to the rest. So what happens these things? Same types of movement occurs. So first things were particularly if it hits the dashboard, that actually thing that comes to rest first. So naturally that will strike coup injury, and that again the brain moves backwards again. Whiplash injury, so that is again very, very peculiar to the brain. It is called whiplash injury. Another thing, whiplash means chabuk. Chabuk marle kirokom hoy? Ye move backwards abar chole ashe. That is a whiplash. Chabuker ঘা যেমন যায় সামনে গিয়ে আবার পেছনে যে কোনো যেমন লেজ যেমন ঝটকালে যা হয় সামনে পেছনে হয় সেইটাই হচ্ছে that is called whiplash injury. It's very common. It is very peculiar to brain injury, particularly spinal cord and brain injury is very peculiar. So this thing is very important. So the coup blow, the side of the blow are contrary to opposite to the blow. The mechanism of causations of the injury, of the impact is because of this particular change of inertia and the movement of the brain inside the skull. So that anatomical peculiarity and these things are very, very important to explain the injury of the brain, and particularly acceleration, deceleration injury. No other organs actually it occurs than in the particularly brain. So as you see this simplex MRI pictures, all these things, it clearly shows these things, how it occurs, particularly how it appears like these things MRI pictures. So naturally, the sagittal sections of the head, as you see these things, because you cannot see all these things, but here you can see these things. So now actually here, actually the coronal section or cross sections of these things. So both sides, as you say these things, now two sides, temporal sides, frontal sides here, and the occipital side. Last class, I explained these things. The base of the skull, that the particularly spaces of the frontal fossa, midcranial fossa, and posterior fossa is different. Also, these things, ridges and crest, they are also different in all these fossa. That's why I told these things. The occipital fossa is smooth and capacious. So, contractive injury rarely occurs in the occipital bone. But frontal bone, because of the spines and important vertical plates and other things, so there is even thing base of the frontal bone অতটা হয় না, in the base of the frontal bone is almost lacerated. And particularly again it is very important the temporal particular lobes of the brain, as you see. As you see these things here, in the thing temporal lobe, this frontal lobe, as you see frontal lobe, and occipital brain is definitely occipital lobe is large, but still because of this no peculiarity here, it is very common. And next thing, no backwards. I got to try to remember the things. And here, this side and the thing, another actually, if I show you these things, different level, you see, temporal, particularly temporal lobe. Temporal lobe also strikes that actually ridges. I do not have this section, probably is omitted from this thing. There is actually expression. So here, so theory, as I already explained, theory of the coup and contra coup injury is very, very common questions. Very, very common questions comes as a short notes. Coup, mechanism of the coup and contra coup injury, and particularly where the contra coup injury is very common, and which injury contra coup injury is uncommon. Which injury contra coup injury doesn't happen? Which type of intracranial injury contra coup injury never occurs? You know EDH, SDH, SAH. Which injury cannot be a contra coup injury? It is EDH. I told you these things. It is always direct trauma. That means always coup injury. EDH, extradural hemorrhage, always coup injury. Contra coup injury does not occur. So if you see these things both sided, that time actually I showed you the photographs, all these things. There are two extradural injuries. If the two extradural injuries, there must be two direct trauma. That cannot be a contractive injury. But other injuries, always coup, contracoup, SDH, SAH, and it's very, very common in the postmortem dissections room. It's very, very common findings in the CCs. And from there, actually, how we explain and how the persons, particularly road traffic injury and the homicide, particularly the murder cases, will have to explain how the injury occurs and which side actually he was struck. Is it from the behind or from front? And that is the very important thing you have to explain. So traction sections already, this mechanism is important. Anyway, it's always for interest. This thing. Oh, I am missing this thing. So you see these things again. That because it is so important. You see here, because of this roughness of the plate, frontal plate contracoup injury, frontal side stay, particularly tip, it's not generally found. But at the base of the frontal lobe is very, very common. Very, very common. We even do not see these things, particularly base of the frontal lobe, because of this particular peculiarity here, these vertical plates and their roughness is very, very common. And another thing is these things here, here you see these things because of this raise. You think another thing is very compact, and here is the temporosphenoid junctions. It fractures very, very commonly. And here again you see this thing. This is actually pituitary fossa. Pituitary fossa. So naturally, the fracture occurs here. This pituitary fossa. If pituitary affected, that means actually this thing there is head injury is very severe. Sometimes actually it doesn't think hormonal imbalance and other things. Inside there is injury at that effect. So this head here, but actually it holds the temporal lobe. So what happens is these things, because of this particularly contractive injury, the brain whenever moves, frontal injury may not be there, but this in the behind, the tip of the temporal is very, very commonly affected, because that hits here, and that is very, very, very common. So contractive injury, if occurs, where it is common? Not the temporal frontal lobe, but the base of the frontal lobe and the tip of the temporal lobe, and both side of the temporal lobe. So that is generally because both side head movement occurs in the sideways, and here is very common because of this anatomical peculiarity and bony ridges and compact space, the midcranial fossa that holds the temporal lobe. So naturally, again, recap of your anatomical knowledge and all these things is very important. Head injury is so important. Mix of the head injury, unless you understand with your anatomical knowledge, you cannot explain. Some peculiarities, important features. Again, I summarize only all these things. Elaborate discussions you not understand. The summarize means coup and contractive injury, some peculiarity. There may be no coup, only contractive injury. That is another peculiarity. Now look, because actually it is very important to know the direct trauma. Because in case of the assault, in case of the homicide, in case of the murder, we'll have to tell these things actually where, which portions he was hit. But sometimes there is nothing, because it is very, very common in acceleration, deceleration injury, where there is no direct strikes, only the movement occurs, and because of this brain movement, whiplash injury, that is contractive injury. That means brain moves backwards and it strikes the skull and ultimately the contractive. That means the coup injury may not be found, but contractive injury there. And sometimes it is very, very difficult to explain how actually the injury occurs, because the person died of the brain injury, but there was no trauma. There is no trauma. But what happened to these things? But simply the movement of the head actually caused all the injury. That is the peculiarity to the brain. There need to be no fracture of the skull. So fracture skull অতটা মারাত্মক নাও হতে পারে. Fracture skull may not cause death. Without fracturing skull, there may be severe intracranial hemorrhage. Again, that is very important. Skull is guarding the brain, but again, the skull may be important for causing death, intracranial injury. So that things actually remember, this is very important. Most common site for contractile lesions, frontal and temporal, already explains. Frontal and temporal lobes at the undersurface and at the tip. It is rare in occipital lobe. Again, above the base of the skull, the brainer peculiarity, brain surface, the most important thing is it holds the gray matter, and inside there is a white matter. Again, the gray matter is important. Once it is injured, it is permanent. White matter also these things, that brain never regenerates cells. So naturally that is the things that happens, but the gray matter is very, very sensitive, very sensitive. So naturally that is the very important thing. The most common site already explained. These are the very important points already. On temporal impact, contractile lesions may be found opposite surface of the ipsilateral. Ipsilateral means jedike hoy, sedike. This sided trauma, that is called the ipsilateral side. And impact against falx cerebri. Arekdin diyechi falx cerebri janto meninges dura matter disposition. Have you seen, have you examined the brain intact, actually taking out from the brain? Have you examined? It comes midlines and then again they are actually then cerebral. So naturally these things, falx cerebri, these things, they are sagittal line, that is very sharp. Dura matter is very sharp. If you see these things very sharp. And another thing is a tentorium cerebri. That means actually hold this thing. There is a vertical disposition and a horizontal disposition. All the dura matter sensing. So these things, again, the brain is so soft. I told you these things. Acceleration, deceleration, injury, sometimes completely section wise. Just churi jamon makhoner opor diye. The knife to butter is like this thing that slices the brain completely. Completely brain is either hemiside, দুটা মাঝখান থেকে টুটু brain কিন্তু একদম completely divided. It is not a very common thing, but that happens. That happens. So internal inside structures can damage then cause the fatal injury, because again medical knowledge because of these things to explain this injury. So falx cerebri দুটো brain ভাগ হয়ে যায়, আর because of this thing brain also hits the cerebellar. Again, I told you these things. What happened? These things, not only the ridges, but also the folds of the dura mater causes to the injury to the brain, and severe contusions, hemorrhage occurs. দেখো ভালো করে cortical lesions, SDH, SH কেন হয়? Contractile injuries are rare before the age of 3 years. এটা আবার একটা বড় কথা. As I told you these things, EDH is common, extradural hemorrhage is common. Which age? This age is again. Because anatomy of the brain and intracranial structures changes with the advancement of the ages. Child is different, old age is different. So what is this 3 years? Again, EDH is common in young adults. Extremes of the ages is uncommon. Why? First, yes. The first thing in the child, because dura mater is continuous with these things, actually there is no space, and old age because of the adhesions of the dura mater to the skull, there is space. So EDH is extreme. But here, contractile injury, because of this contractile injury, there is no movement, almost actually fitting healthy, there is not loose space there. But at old age, again, the brain shrinks, as our brain and your brain is different. So naturally, brain gradually shrinks. So naturally, space inside the brain increases. So this contractile injury, chances of the contractile injury increases with the advancement of the age. That means the old age, because particularly the changes occurring in the brain matter. So naturally, space increases. Whiplash injury to the brain, peculiar injury, a peculiar injury to the brain because of these things. As I told, whiplash injury, সবসময় দেখেছো কুমিরের লেজে ঝটকা বা চাবুকের ঘা, মানে সামনে গিয়ে আবার পেছনে আসে। whiplash, যখনই চাবুকের ঘা, এটা নোটিস করবে, কারণ these are the things important anatomically. You have to do whiplash injury. So this particularly movement of the head is very peculiar in the car movement, road traffic. গাড়িতে যাচ্ছ, movement, sudden break, there will be a movement. First goes forward, then comes backward. This injury, this whiplash injury, that causes fatal injury. ওই যে বললাম, কারো কিছু হয়নি, গাড়িতে কিছু হয়নি, তার বডিতে কোনো ইঞ্জুরি নেই, বাট পার্সন ইজ ডেড। Person is dead. So that is the things you cannot explain unless you have these things, this mechanism of injury to the brain, these things, unless this knowledge is very important. So this whiplash injury, you see these things. So you see the movement, suppose you think brain impacts or if it is not the acceleration deceleration injury, it may be direct trauma. So naturally you see suppose trauma, আমি অলরেডি বলেছি ট্রমাতে কি হয়। দেখো এই যে ব্রেন ইম্প্যাক্টস ব্যাক অফ এ স্কাল, এটা আমি যদি বলি এই যে জিনিসটা ফার্স্ট একটা মুভমেন্ট, সামনের দিকে মুভমেন্ট, পেছনের দিকে মুভমেন্ট, সামনে গিয়ে আবার পেছনে, ফ্রন্ট সাইড মুভমেন্ট, হোয়েন ইট গোজ ফ্রন্টিং, আলটিমেটলি হোয়েন অ্যাকচুয়ালি ব্রেন ফলস ব্যাকওয়ার্ডস, the head, again I told you this thing, contractive injury, the skull coming backwards but the brain moving still forwards. So first this thing that hits the brains, that is the things here actually contractive injury, where the brain impacts in the front of the skull. এবার আবার স্কালটা মাথাটা পেছন দিকে, তাই হয়তো সামনের দিকে যেতে যেতে ব্রেন যখন হচ্ছে তখন ফার্স্ট অ্যাকচুয়ালি ব্রেক করলে বিকজ অফ দিস ইনার্সিয়া মাথাটা সামনে চলে যায়, সবটাই যায়, কিন্তু আবার যখন ব্যাকওয়ার্ডস আসে স্কাল আসে কিন্তু ব্রেন স্টিল ইনসাইড দ্য মুভস, এই অলরেডি আই এক্সপ্লেন। সো ন্যাচারালি দ্যাট হিটস again coming backwards, again you see these things, that times skull backs by head stops, skull stops but brain moving. So this injury, this whiplash injury is very very common, is very taken from the very famous book, again these things, head injury types, characters, mechanisms can only be explained inside the mortuary, because nobody can see this injury so much better than we see. Because of these things, we examine many cases, hundreds and hundreds of the very common head injury, road traffic injury and other injuries. Assault is not that, but head injury, road traffic injury is very very common. Here all these things, you see these things. So এটা কিন্তু ভুলবে না, whiplash injury is a very peculiar injury occurring to the brain, often fatal, cannot be explained from outside examinations of the body. So that is the very important thing. All these things, again how it occurs, I told you বলেছিলাম, এই যে বললাম কন্ট্রাক্টিভ ইঞ্জুরি, দেখো এই যে ফ্রন্টালি টপ ভিউ অফ দ্য ব্রেন, আমি ওপর থেকে যদি দেখি তাহলে কি হচ্ছে যে ফার্স্ট এই যে ফ্রন্ট সাইড ফ্রন্টাল লোবে একটা স্ট্রাইক, দেন দিস টেম্পোরাল লোব দ্যাটস মিড রিজ সেখানে গিয়ে মারবে, বা এখানে কি হচ্ছে যে অনেক জায়গায় তো ফালস গিয়ে সেটা হচ্ছে এখানে হবে। তো ন্যাচারালি এই জায়গায় টিপ অফ দ্য লোবস বাইরে থেকে বোঝা যাবে না, অনলি এক্সামিনেশন অফ দ্য টোটাল ব্রেন এটা কিন্তু বোঝা যাবে। নাও হিয়ার ইজ থিং অক্সিপিটাল বলে খুব বেশি হয় না, বিকজ ইন স্পেশিয়াস, আই টোল্ড ইউ দিস থিংস, অ্যানাটমিক্যাল পিকুলারিটি খুব বেশি নেই, এগুলো হচ্ছে যে অ্যান্ড অক্সিপিটাল বলে হলে ফার্স্ট হচ্ছে যেটা হয় ভিজুয়াল লস, কিছু হোক না অক্সিপিটাল বোন ইঞ্জুরি, অক্সিপিটাল ব্রেন ইঞ্জুরি, হোয়াট ইজ নাথিং উইল হ্যাপেন বাট দ্য ভিজুয়াল লস, again this is that very very common in case of the occipital bone, this thing. Intracerebral hemorrhage, very important, it may be traumatic, it may be pathological. Have you seen the খুব কথা বলা যায় স্ট্রোক হয়েছে, স্ট্রোককে আগে বলতো একটা কার্ডিয়াক স্ট্রোক বলে, আর একটা হচ্ছে সেরিব্রাল স্ট্রোকস। এখন সেরিব্রাল স্ট্রোকসগুলো হচ্ছে যে সাডেন হেমারেজ, যেটা হচ্ছে ব্রেনের হেমারেজ। তো এটা বলছি যে এই জিনিসটাই কিন্তু ভেরি ইম্পর্টেন্ট, বিকজ দ্যাট ক্যান সেভ এ লাইফ অফ এ পার্সন, বিকজ ই মে বি অ্যাকিউজ দ্যাট ইজ এ কেস অফ দ্য মার্ডার, but actually it happens because of some pathological hemorrhage. Pathological hemorrhage commonly occurs, what you see these things in the hospitals, is sudden brain hemorrhage inside the brain. Suppose a person is suffering from the long hypertension, and because of these things there may be a severe hemorrhage, that is the cerebrovascular CVA. Commonly explained in this manner, CVA, cerebrovascular accident. It may be two types, but hemorrhagic, where actually hemorrhage occurs and another is infarction occurs. But anyway, but actually we are very concerned with the hemorrhage, CVA, that is pathological. If you can see these things pathological, so there is characters of the pathological hemorrhage. Again, the charge of assault or charge of the homicide can be actually excluded, persons can be saved because of your opinion, because if the pathological hemorrhage occurs, that is a natural cause, so naturally he'll be released from these things. Traumatic hemorrhage usually at the surface, সবসময় মাথায় যদি চোট লাগে সারফেসের দিকে হেমারেজ হয়। ট্রমাটিক হেমারেজ ডিপ সিটেড, হিয়ার ইউজুয়ালি অ্যাসোসিয়েটেড উইথ সুপারফিশিয়াল ব্রেন কন্টিউশন ও ল্যাসারেশন, খুব বেশি হয় না, কিন্তু ডিপ সিটেড ট্রমাসের সারফেসেও থাকবে, ডিপেও থাকবে। আইসোলেটেড ডিপ রেয়ার, রেয়ার, ইট ইজ অনলি এক্সটেনশনস অফ দ্য হেমারেজ। খুব জোরে মারলে উপরেও হবে হেমারেজ, দ্যাট ইজ হতে হবে, ভেতরে হবে। বাট pathological hemorrhage always deep seated, pathological hemorrhage rarely at the surface, and that is a very important finding. And কোথায় হয় সেটা কিন্তু অলরেডি বোধহয় কর্টিকোস্ট্রায়েড ব্রাঞ্চ অফ দ্য সেরিব্রাল আর্টারি শুনেছো কখনো? কর্টিকোস্ট্রায়েড ব্রাঞ্চ, and that is the common place because actually that is actually cerebral supply, and that's why the around the internal capsules, and that's why these things, so much of the hemiplegia occur. See, anatomical internal capsule affected means it is actually the condensations of all the fibers there. So naturally the widespread paralysis, paraplegia occurs, these things. So that is very important, very important. You can gradually learn, unless you have the interest and you cannot learn. So naturally these things. Usually in adult with a history of injury, some interval, এটা হচ্ছে traumatic injury. কিন্তু ডিজিজ যদি হয়ে থাকে, spontaneous hemorrhage usually single and deep seated. Pathological or disease থেকে যেটা হয় CVA, generally lenticulostriate branch of the cerebral artery, সেখান থেকেই হয়, সেখান থেকে just these things deep seated in the cerebrum. আর বলেছি ট্রমাটিক কি হয়, উপরের দিকে হবে, সেরিব্রামের দিকে। Hemorrhage is generally in the region of basal ganglia and rupture of lenticulostriate. এই যে বললাম, it is a very common information, very important. In future you will find medicine, surgery, neurosurgery, wherever these things, MCQ, you will be given these things. You will be given lenticulostriate branch, where these things, and what is these things, and the deep seated, these things. Particularly these information, this particular information is important to answer these things, MCQ questions. And these things, so anatomy, you learn, and again this thing in practical side, particularly when these things, when you study head injury, these things, then again it is very important. আর একটা আছে pontine hemorrhage. A drop of blood can be fatal. A drop of blood can be a fatal. Ideal example is pontine hemorrhage. Just a drop of blood, hemorrhage, just a drop, but the person is dead. Nothing is found. Only the section of the brainstem, could we see all these things? There is hemorrhage. Why these things? That is pontine. But pontine hemorrhage কিন্তু clinically diagnosis করাটাও কিন্তু easy. That is the thing tried. কি কি আছে? এই যে 3 P's মনে রেখো। কি কি হয় pontine hemorrhage? এই ডায়াগনোসিসটা করা যায়। But a drop of blood বেশি hemorrhage হতে হয় না। একটা drop of blood can kill a person, that is in pontine hemorrhage. That is the things. And 3D কি কি হয়? এটাই একটা peculiar brain hemorrhage, but fever, pyrexia, high rise of temperature, কিছুই নেই, nothing, no infection, nothing, but high rise of temperature. Suddenly there is an injury, there is a head injury, but pyrexia, peculiar to the pontine hemorrhage, suspect pontine hemorrhage. কি কি আছে এটা পড়ো, ইম্পর্টেন্ট। প্রেজেন্ট এগেইন আই এম অ্যাকচুয়ালি ফিগার দিস থিংস। কি কি হবে? pinpoint people, 1P. Another is pyrexia, another is paralysis. Characteristic signs of the pontine hemorrhage: with a drop of blood in the brain stems can kill a person. It is not that the severe hemorrhage generally kills, nothing. So that is very important, but it can be clinically diagnosed. Concluding portions here, remember, very important statements. Very important statements for doctors must know. Head injury patient এসছে মানে ছেড়ে দেবো, এটা মরে যাবে। Head injury patient কিছু হবে না। Even trivial injury can cause death. Even severe injury, from severe injury you can save the life of the patient. So these things, no head injury is so slight that it should be neglected. Or ওই যে বললাম ও কিছু হয়নি, আমরা জিজ্ঞেস করি যে এরা একটু বমি হয়েছে, whether you have nausea, nothing. All head injury history is very important. Probably you know these things. বমি হয়েছে, nausea আছে, অন্য কিছু। Just because of these things, nothing happens, but these symptoms is important. That warn you that there will be severe hemorrhage, because that may be fatal in just near future. There's some time. So, এই যে ছোট ছোট কয়েকটা questions, actually you ask a patient, you can save the life. So, no head injury is so slight that it should be neglected or so severe that life should be despaired of. আবারও বলছি, সিভিয়ার হেড ইঞ্জুরি, একটা সাইড, ব্রেনের একটা সাইড কেটে বাদ দিতে হয়েছে, but still the person is alive. Sections of the brain is removed. There is this severe hemorrhage, patient unconscious, and he was in the ventilator for 3, 4, 5, 6 days. But again, they come up live. But again, the so slight hemorrhage, কিছুই না, বমি হয়েছে, ছেড়ে দিলে বাড়ি, কিন্তু just after this thing, I told you this thing, inhalation, RG got 2 incidents, I told you this thing, there is severe mob attack upon the doctors and the ransacking the hospitals, because that was both cases were the head injury. So the doctors did the main mistake, that they did not consider that it could be fatal. That is the main problem, the deficiency of the knowledge. Deficiency of the knowledge is very important here, and that cannot be, no doctor will be spared in the eyes of the law. So the head injury, আবারও বলছি, already forensic medicines, here it is surgical importance, anatomical, all is important, here MLI, that's medical legal importance. Medical legal importance of the head injury just is tabulated in this field. It's very important, note this thing. Amnesia, that is দুটো হয়তো retrograde amnesia, ধীরে ধীরে পেছনেরটা ভুলে যায়, সামনেরটা খুব ভালো মনে আছে, পেছনেরটা ভুলে যায়। Past, actually he forget the past, মনে করতে পারে না। It's a very interesting findings there. Traumatic automatism. Automatism মানে কি করছে সে কিন্তু জানে না, without his knowledge, and criminally it is very important. Traumatic dying declarations, I told you this thing, dying declaration, how it happened, unreliable. Alcoholic presentations, আমি বলেছি punch drunk phenomena, এটা কি জানো punch drunk phenomena? Have you heard the name of Muhammad Ali, Cassius Clay? Was he? Very famous persons. Probably you are very young, not the boxer. And a punch drunk phenomena is peculiarly. What is punch drunk phenomena? It happens to the boxers. মানে মাথায় মারলাম, ওই বললাম head injury alcohol, it behaves like a drunk person. And gradually, with the particularly boxers, ultimately that things actually Alzheimer's disease, ultimately Cassius Clay are suffering from all these things because of this traumatic hemorrhage, minor hemorrhage over the times, actually ultimately it becomes so severe that actually causes inside this thing. So this punch drunk phenomena, upon the punch, the persons behave like a drunk, though not dead, not unconscious, but behaves like a drunk person. Punch drunk phenomena, and Cassius Clay is important these things. And sudden death, I told you these things, medical negligence, ডাক্তারদের কোনো মাপ নেই, এক্ষেত্রে কিন্তু বাঁচবে না। And lastly, criminal responsibility, you have not yet heard, because not that whatever we do has a criminal intent. We can, patient may die while in the under treatment of a doctor may be charged of negligence, but that is not homicide. That is homicide not amounting to murder, and the homicide due to negligence. So naturally all these things, a criminal responsibility. Again, after head injury, that's automatism. The persons may act not spontaneously, without any knowledge, without all these things. He may kill a person, he may hit a person, he may do some crime, but that times it can be proved because of this effect of the head injury, no criminal responsibility. The persons cannot be charged of the homicide, murder. So that is very important. So doctor's report is very, very important. So other things, no, I will not discuss. I will stop this discussion. Very important is the RTA, road traffic injury. There are things.
Today there will be an introduction and the starting of the chapter on lymph nodes. So lymph nodes, and then there will be, I think, total 3 classes on lymph nodes. Today's class will be introduction with the benign conditions affecting the lymph nodes, and the next 2 classes will be on lymphoma. Now, to start off today's topic, see, actually you have a question that is or a competency assessment that comes in your syllabus, that is the differentiating features and the causes of lymphadenopathy. So to understand what is lymphadenopathy and what are the causes, the first topic, firstly you must know what is the what is the morphology of lymph nodes, that is how do they look, and then what are the manifestations of your lymphadenopathy. So let us start. First of all, lymph nodes, you must understand that lymph nodes are part of the lymphatic system. That is, we have lymphatic channels and then we have lymph nodes. Lymphatics and lymph nodes. Now, how does a lymph node look like? Morphology, that is grossly or macroscopically, a lymph node will look like a bean-shaped organ. What is a bean? Bean means that has a convex shape and a concave shape. So, as you can see here, this is a bean-shaped organ. This is your convex side and this is your concave side. So, what is happening in case of a lymph node is that the convex side, you have multiple afferent lymphatic channels. That is, these channels will bring lymphatics from the peripheral circulation into the lymph node, and at the hilum, this is called hilum, that is on the concave side, you have efferent lymphatics. Efferent means something that is going out of an organ, and afferent means something that is coming inside. So the convex side of the lymph node is pierced by multiple afferent channels, afferent lymphatic channels, and the concave side you have the efferent lymphatic channels. Okay. Now, if you just follow the shape of the organ, so what is happening? The lymph node is covered by a capsule. The outer red thing is your capsule, and this is composed of fibrous tissue. This is a fibrous tissue called the capsule. From the capsule, you can see some red structures projecting into the parenchyma of the lymph node. These are called trabeculae. So, this is the organ surrounded by a fibrous capsule. The fibrous capsule is providing a structural framework to the lymph node. From the fibrous capsule, similar extensions of fibrous tissue is projecting into the lymph node, and that is further helping in reinforcing the organ. So this is the capsule, and these are the red colored structures. These are called trabeculae. That is, they are projecting from the lymph node capsule into the lymphatic parenchyma. Now, what is happening? If you look at the picture, you have 2 distinct areas. The outer area, which is more cellular, and that is called the cortex, and the deeper part of the lymph node or the inner side of the lymph node is your medulla. That is an area where there is less cellularity and more edematous. So the outer part is the cortex, which is more cellular, and the less cellular part is the medulla. Now, what is happening? You can find in the cortex there are certain lymphatic aggregates. So these are, as you can see, round structures that are formed of aggregates of lymphocytes, and they are present in the cortex, and they are called follicles. They are known as follicles. So cortex, outer part, medulla, inner part. In the cortex, you have rounded structures which are called follicles. I will come to the description of how a follicle looks like a little later. Now, in general, that is, what is the function of the lymph node or the lymphatic system? We know that it is responsible for production of That is, lymph nodes are the site of B and T lymphocytes. So the primary function of lymph node is to provide immunity. That is, whenever there is an infection, inflammation, injury, the immune response will be mounted by the lymph node. That is the primary function. The other most important function is your phagocytosis. So any particulate matter, we know that there is in the peripheral circulation, we have monocytes. In the tissues, we have macrophages. So all these are part of the lymphoreticular system that is responsible for mounting a phagocytic response to any particulate matter. So these are the two important functions of lymph nodes. One is immunity and one is phagocytosis. Now, what happens is, I told you afferent channels, efferent channels. So from the periphery, what happens is, from the periphery, your lymphocytes from the peripheral blood will enter the lymph node, and inside the lymph node they will undergo maturation and transformation, and these transformed lymphocytes will form the role of T cell mediated and B cell mediated immunity, and they will be further released into the peripheral circulation. So lymphocytes entering lymph nodes, they are transforming, they are maturing, and they are forming your B cells and T cells, and they are released into the peripheral circulation. So that is what is happening inside the lymph node. So what is happening is, as you can see, I said this part is the cortex and this part is the medulla. In the cortex you have follicles. Okay. Now there is something I have written, germinal center. What is germinal center? That is a lymph node, a follicle that is entirely blue, that is your primary follicle. What is primary follicle? That means that follicle is in a native state or an inactive state. So nothing is going on inside the follicle. It is just composed of resting lymphocytes. Now, when such a follicle encounters an antigen, when there is an antigenic stimuli, then what happens is, inside the follicle, the lymphocytes start maturing, transforming and maturing. When such an event takes place, the center of the follicle becomes pale, because in a primary follicle it is only resting lymphocytes. In a follicle that has encountered an antigen, the center of the follicle will become pale. Why? Inside that center of the follicle, there will be transformation and maturation of the lymphocytes and formation of various cells in the maturing series of lymphocytes. So therefore, such a follicle in which you have a pale center is called a secondary follicle, and this central part of the follicle is called germinal center. So what is happening? This is your follicle. The central part is starting to become pale. As it is becoming pale, this is your formation of a secondary follicle, and the pale center is called the germinal center. And when a germinal center is formed, the periphery of the germinal center, that is called your mantle zone. So a primary follicle will have no zonations. It is entirely blue and composed of resting lymphocytes. When a primary follicle is exposed to an antigenic stimuli and there is formation of a germinal center, then it is called a secondary follicle. What are the parts of a secondary follicle? That is, there will be a germinal center in the center of the follicle, and the peripheral part which will be the darker area, and that is called the mantle zone. So germinal center surrounded by the mantle zone. Now what is happening inside the germinal center? Inside the germinal center, you can see the lymphocytes which have entered the germinal center. So this is the germinal center and lymphocytes have entered. Once this is a small lymphocyte, so this has entered the germinal center. Once it is inside the germinal center, it will undergo a series of changes. A series of changes will take place. inside the germinal center, and the following cells, these are the following cells that will be formed sequentially. So first what is formed is called a small non-cleaved cell. That is, you can see that this is the nucleus, this is the cell, this area is the cytoplasm, this is the nucleus. So there is no cleave in the nucleus. It is a single non-cleaved nucleus. So this kind of a cell is called centroblast. After that, what we see is there's a cleave formation. So this is called centrocyte. So centroblast getting transformed into centrocyte. Then this is small cleaved cell, it will get converted to large cleaved cell, and then large non-cleaved cell. That will in turn be transformed into an immunoblast. Immunoblast and lymphoblast are the same thing. That is, a lymphoblast will be converted to an immunoblast, and the immunoblast will form plasma cells. So what is happening is that, as you can see, a lymphocyte entering the germinal center. So initially there is formation of centroblast. Centroblast is a small non-cleaved cell. It will be converted to a small cleaved cell, that is a centrocyte. Centrocyte will be converted to a large cleaved cell, and then there will be formation of again a large non-cleaved cell that will give rise to your immunoblast. So once the immunoblast is formed, it will come out of the germinal center. The immunoblast will come out of the germinal center. Now what happens is, what is the fate of the immunoblast? So like I said, there are two categories. So one will be immunoblast, that will give rise to plasma cell, and then the lymphoblast. So lymphoblast, immunoblast, how will you differentiate? Lymphoblast will have a more convoluted nucleus. Immunoblast will have a very rounded nucleus, and lymphoblast will have a convoluted nucleus. Convoluted means the periphery of the nucleus will not be regular. There will be irregular projections of the nuclear margin. So inside the germinal center, you have formation of lymphoblast, immunoblast. Now what happens is, these immunoblasts, some of them will stay in the cortex, or they will migrate to the paracortical area. I will explain to you what is the paracortex. So some of them will migrate to the paracortical area, and they will rest there as memory B cells. That is, they will be resting there as memory B cells, and the others, the majority of the immunoblast, they will migrate to the medulla of the lymph node, and there they will give rise to plasma cells, and then these plasma cells will form your antibodies or the immunoglobulins, and those will be released into the peripheral circulation. Is it clear? So immunoblast, some of them will become dormant, that is, they will stay latent in the paracortical area, and they will be known as memory B cells, and the rest of it will go to the medulla. There they will form plasma cells. Plasma cells will give rise to immunoglobulins. Immunoglobulins will be released into the peripheral circulation. So that is how antibody will be released into the peripheral circulation. So coming to the medulla, how does the medulla look like? You can see there are cords meaning strands of cells. So these are called medullary cords, and in between there are empty spaces which are called sinuses. So these cords inside the medulla, they are formed of plasma cells. Like I said, plasma cells will migrate from the cortex, from the germinal center to the medulla. So they will form cords, and these cords are your medullary cords. Okay. So this picture is not, this is a representative picture of the entire lymph node. What is going on? Please try to focus on this picture. Okay, before that, I forgot to mention one thing, that is, this is your cortex, this is your capsule, the red colored area, and just beneath the capsule, you have this yellowish area which is called sinus, which is the sinus. So sinus, what is sinus? It is a dilated space. That is lined by endothelium, and these sinuses will carry the lymphatic channels. That is, the lymphatics will flow, will pierce the capsule, will enter the subcapsular sinus, and this sinus They are intercommunicating channels that through which the lymphatics will flow, and it will traverse the cortex, the medulla, and the sinuses will result ultimately in the formation of efferent channels. So once the afferent channels are entering inside the lymph node, they will enter the subcapsular sinus. From the subcapsular sinus, there will be intercommunicating connections through the cortex into the medulla. In the medulla, they will form the efferent channel, and the lymphatics will drain into the peripheral circulation. Now please follow this picture. This is the other picture was a schematic picture. That was a diagrammatic representation of what is actually going on inside the body. But this is a picture from an actual lymph node. So you can see this is a very nice picture. It shows all the stages of maturation in the lymph node, and please follow it. This is a bean-shaped organ. You cannot appreciate the bean over here because we have cut it transversely. There is a transverse cut, so the entire peripheral part is the cortex, and the middle part is the medulla. So this is the cortex, this is the cortex, this is the medulla. So somewhere here you are going to have the hilum. Hilum is the area from where the efferent lymphatic channels are going out. So somewhere this part you will have the hilum. So what is happening? This is the cortex, this is the medulla. This area, which is pinkish, is a fibrous tissue, and that will be your capsule. So this is the capsule of the lymph node. This cellular part is your cortex, and this area which is not so cellular, which is looking whitish, that is loose edematous area, that is your medulla, cortex medulla. Now you can see these are the empty spaces. See, this space is looking empty, this is empty, this is empty. That is just below the capsule. So this is the subcapsular sinus. This is the subcapsular sinus. Capsule, just below that the subcapsular sinus. Now you can see projections from the cortex. This pink, if you try to follow this pink part, these are projections from the capsule into the inside of the lymph node. So these are the trabeculae. I told you trabeculae are same fibrous structures that project from the capsule into the lymph node, and they are offering a structural framework to the lymph node. This is all formed of parenchyma to maintain integrity, that is the structure of the structural support. You have the fibrous tissue on the periphery, and then there are projections from the periphery into the inside of the capsule, inside of the lymph node. So that is the trabeculae. Now, so this area is cellular, this area is not cellular, not so cellular. So this is cortex medulla. If you see in the cortex, if you see this area, what is this? Can anybody tell me? This is a primary follicle. Why primary? It is entirely blue. It is composed of entirely inactive resting lymphocytes. So this is primary follicle. Now if you try to follow, what are these? These are secondary follicles. Why secondary? Because you can find that the center of the follicle is pale and the periphery is still dark. So the periphery will be called mantle zone, the center will be called germinal center. Therefore, this is a secondary follicle. So primary follicle, just beside that you have a secondary follicle. And everything is taking place inside the cortex. Everything is taking place inside the cortex. So this is the cortex. Here you find the primary follicle and the secondary follicle. Now, I had mentioned the term paracortex. What does paracortex mean? Paracortex will be the deeper part of the cortex. So if this is the cortex, here this is the outer part where you can find the follicles, and the deeper part, in the deeper parts, these are known as the paracortex. Okay, so cortex and paracortex. Now this part, so this part is your medulla. Now you can see this whitish empty space which I told you, these are subcapsular sinus. So what will happen is, from the subcapsular sinus there will be intercommunicating channels into the medulla. Now for example, this whitish area, so they have all connections with the subcapsular sinus, and they will be draining from the cortex, from the subcapsular area through the cortex into the medulla. So when they are inside, when they are just beneath the capsule, they are called subcapsular sinus, Once they are inside the cortex, they are called cortical sinus, and once they are inside the medulla, they are called the medullary sinus. So subcapsular sinus through the cortex, that is your cortical sinus, then medullary sinus, and from the medullary sinus they will ultimately form the efferent channel, and it will be going out of the lymph node. Okay. Now, if you see in the medulla, the whitish areas, these dilated areas, these are the sinuses, and you can find some darker areas, whitish areas, which are the empty spaces, and then some darker areas. So, what are the darker areas? Darker areas? Yes. So, they are called medullary cords, and cords are composed mostly of plasma cells. So, just like I said, that plasma cells are getting formed inside your germinal center, and then they are coming to the medulla, and these plasma cells are forming cords, and those cords are called medullary cords. So, medullary cords composed of plasma cells. Okay. Now, what you can see is that so these empty spaces which we call as sinuses. So, what is inside the sinuses? The sinuses, they are lined by endothelial cells, and sinuses contain the histiocytes. What are histiocytes? That is the macrophages. So, I said there are two functions of lymph nodes. One is to give immunity, and that function is mediated by your T and B cells, and the histiocytes that are inside the sinuses, they are responsible for the phagocytosis. So thereby you have two distinct functions of lymph nodes. One is your phagocytosis, one is your immunity. So is it clear, this picture? How does a lymph node look? Now you must understand that B cells and T cells. So where does the T cells reside? In the paracortex. In the paracortex you have the T cells, and where is the B cells? In the follicle. In the follicle. You might find a small percentage of B cells in the cortex also, I mean outside the follicle, but majority will reside in the follicles, and the T cells will reside in the paracortex. So that is the distribution of T cells and B cells. Now I have discussed all these just to make you understand, first of all, how does the lymph node look like, so that you can understand what are the pathologies affecting a lymph node. Next is, you have lymphadenopathy. That was the question. What are the differentiating, how will you differentiate the causes of lymphadenopathy? That was your question. So, first is, what is lymphadenopathy? Very important thing is that it refers to nodes that are abnormal. The word is abnormal in size, number, or consistency. Size, consistency, or number. Now, you might think that lymphadenopathy always means an increase in size, but then that is mostly the case. You might think that lymphadenopathy means increase in size of the lymph node. That is usually the case in, say, 95% or equivalent number of cases. But then there are some conditions, for example, HIV. In HIV, what is happening? There is involution of the lymph nodes. But then that is still a lymphadenopathy. So, the word is abnormal size, consistency, or number of lymph nodes, and that is known as lymphadenopathy. Now, there is another term that is called lymphadenitis. Lymphadenitis is a term that we use whenever there is the cause of lymphadenopathy is inflammation. So, whenever the etiology is inflammation, in that case, the term that we use is lymphadenitis. But lymphadenopathy in general means any abnormality in the size, consistency, and number of lymph nodes. Is that clear? So, it can be either localized or it can be generalized. What does that mean? If a single area, that is generalized if lymph nodes are enlarged in two or more non-contiguous areas, and localized if only one area is involved. We will talk about that subsequently. The thing is, non-contiguous, this word is very important. to make you understand what does that mean, I have put in this picture. You can see, so these are the main lymphatic areas inside the body. Head and neck, which accounts for 55% of the cases, followed by your inguinal, this area. These are the lymphatic chains, and then you have the axillary. This is your supraclavicular. These areas which you see, popliteal, etc., these are not so important. You have epitrochlear, you have read all these in anatomy. So those areas are not that important. Now, what is a generalized? So I have said two non-contiguous areas. So suppose a patient is having lymphadenopathy here and here. That is non-contiguous. Two or more. So this becomes a generalized lymphadenopathy. In a single area, suppose you have 10 lymph nodes enlarged in the head and neck area. Say in the neck. In the neck you have 10 lymph nodes enlarged. Will it be generalized? It will be localized because it is affecting a single area. So, just like I have mentioned, usually in 75% of cases, it is a localized lymphadenopathy. Only in 25% of the cases, you get generalized lymphadenopathy. So, localized lymphadenopathy is more common. And if you are asked which area is out of localized lymphadenopathy, which areas, lymphatic areas are most affected, you will say head and neck. Head and neck followed by inguinal area. Now, this is your list of the causes of lymphadenopathy. Okay, so this entire list you might not be having in your book, but just for discussion purpose, I have put in. What happens is, here they have divided the causes into main headings: infections, autoimmune causes, you have drug hypersensitivity, and other causes, for example, sarcoidosis, amyloidosis, rare causes, even storage diseases like Gaucher's disease. And here they have given lymphoproliferative disorders. And in lymphoproliferative disorders, you have certain benign causes. You might not remember all these names. You will be, like later on, if you're interested in pathology, you will come across these. But then these are the benign causes. Some atypical and clonal. Anybody knows what is clonal? That is whenever there is proliferation of a single cell population. Single cells getting proliferated, that is called clonal. For example, only B cells are getting monoclonal gammopathy. That is an example of MGUS, monoclonal gammopathy of undetermined significance. So that is an example of clonal proliferation. But then that example won't come over here because monoclonal gammopathy is mostly affecting the bone marrow. It doesn't present as lymphadenopathy. So you don't say monoclonal gammopathy over here, but you, as an example of clonal disease, you can say that name. Now what is happening is, so clonal and malignant causes. Malignant causes, like he said, Hodgkin's, then we have non-Hodgkin's, and we have other metastatic cancers coming to the lymph node, and then you have leukemia. Okay, so just broad headings. Even if you can't remember all the things inside, you will say infections, then you will say autoimmune, then you will say hypersensitivity, and that is mostly to drugs. Then you will say other causes. In other causes, you can say amyloidosis, sarcoidosis. Then there can be storage disorders. Storage disorders, suppose Gaucher's disease, it can affect the lymph node. So all these will come under your benign causes. And then you will make another heading, lymphoproliferative, in which you can say some of the names which I have mentioned over there. And then finally you will say malignant. And in malignancy, you will say Hodgkin's, non-Hodgkin's, leukemia, and metastatic malignancies. The Hodgkin's part and the malignancy part will be taught in the subsequent 2 classes. That is not the topic of discussion today. So we will mainly focus on the benign part. That is benign causes of lymphadenopathy. And how does it present? So, reactive lymphadenitis. What is reactive? That means, suppose there is any kind of infection by a microorganism or microbial product, a microbe or a microbial product is causing your antigenic stimulus, or there is any kind of tissue injury, or there is any kind of environmental insult, or there is any kind of immune mediated cause, that will result in reactive changes in the lymph node. Reactive changes, what do you mean by reactive changes? That is, the lymph node will try to respond to that stimuli, and in the process, the changes that will take place inside the lymph node, and that is called reactive lymphadenitis. Why I am using the term lymphadenitis? Because it is mostly due to inflammation. The cause is inflammation. So, what is happening? Reactive lymphadenitis. Reactive lymphadenitis is usually of two types. One is acute non-specific, chronic non-specific. Just like acute, that is something that is causing an immediate trigger. There is an immediate infection going on. Just the draining lymph nodes in that area will get inflamed, and that is the acute lymphadenitis. Suppose a patient has presented with appendicitis. So draining lymph nodes, the mesenteric lymph nodes that are just near the appendix will get inflamed. So that will be your acute lymphadenitis. And what do you mean by chronic? Repeated attacks of acute lymphadenitis, repeated attacks. That is your chronic lymphadenitis. So what happens is, in acute, just like I have said, that mostly they are microbiologic infections. So if you see this list, for example, streptococcal, staphylococcal, all these diseases which are causing, which are the microbial organisms, they are mounting an immediate immune response. So those are mostly the causes of acute non-specific lymphadenitis. And any kind of foreign bodies, for example, there is a wound, and there is some foreign body in the wound. For example, either suture material or something foreign body, thorn or something is causing your foreign body reaction. So in response to that, immediate response that will get in the draining lymph node, that is your acute lymphadenitis. Is that clear? And what are the most frequently affected lymph nodes? Cervical, that is the neck, axillary, inguinal, mesenteric. I said, like, suppose cervical. What is cervical lymphadenopathy? Is your neck, lymphadenopathy in the neck. And what are the causes? Like, you have oral infection. So, any infection taking place in the oral region. Mesenteric, I have just explained. Say appendicitis. Suppose it's a perforated bowel. So these are all acute events taking place, resulting in inflammation of the draining lymph nodes, and that is what is called as acute non-specific lymphadenitis. Now, what is chronic? Chronic means, as you can understand, chronic, there is another name called reactive lymphoid hyperplasia. This is just another name, reactive lymphoid hyperplasia. So, in chronic, what happens? Suppose there is an acute lymphadenitis, but that is not getting resolved. Normally, what will happen? There will be an acute injury, there will be acute manifestations, and it will heal. That is the acute, that is the inciting event goes away, the lymph nodes come back to normal. That is the normal course. Now, suppose this is not happening. The acute event is persisting. There is a persistence of the acute lymphadenitis, or there is recurrent inciting event caused by the acute agent. So, in either of the cases, there is persistent stimulus. So, that results in what is called chronic non-specific lymphadenitis. Okay. So, what you can see is that as a response to, just like I have written, the antigenic stimuli as repeated attacks of acute lymphadenitis or lymph from a malignant tumors. This is very important. Malignant tumors, there is a malignancy. Malignancy will not go away. It is not an acute process. So there is a tumor, which is a malignant tumor in the draining lymph node, in the draining area of a lymph node. So that will keep stimulating this lymph node constantly, and therefore that will give rise to a chronic non-specific lymphadenitis. Aside from the fact that another cause of lymph nodes will be your repeated attacks of acute lymphadenitis. Now, we will briefly discuss the gross and microscopic features of acute and chronic lymphadenitis. In acute lymphadenitis, what happens is the involved lymph will appear. This is an acute event, so it will be swollen, it will appear red, it might be painful, and it might be fluctuant. That is, There might be formation of pus inside the lymph node, so it will be fluctuant. So as you can see, they are enlarged, may show abscess formation if the involvement is extensive. You know, abscess is an acute event. So if the abscess formation, so if you feel the lymph node, it will be warm, it will be tender, it might appear red, and it might appear fluctuant because there is formation of pus. And any acute pathology, while you are describing, you know that there will be predominance of neutrophils. So even if you don't remember anything about the microscopy, you will just say that there will be neutrophils, that is abundance of neutrophils. So what happens is the sinuses, just like the sinuses are the first, the sinuses contain your macrophages. Those sinuses will be congested, they will be dilated, and they will be filled with neutrophils. And there will be prominence of the lymphoid follicles. So more severe cases, there will be abscesses and then eventually necrosis. So sinuses will be dilated, lymphoid follicles will be hyperplastic, and in the predominant cell population will be neutrophils, and in the subsequent stages you might get abscess formation and then necrosis. Okay. The more important thing is your chronic non-specific lymphadenitis. Chronic non-specific lymphadenitis. The important thing here is that they will be non-tender because this is a chronic event. It was tender when it was acute. Now the trauma has persisted. So it was initially fluctuant. Fluctuant means it was soft. It has become firm right now because there is an organization going on. It was initially firm, initially fluctuant. Now there is ongoing trauma, there is healing fibrosis going on, organization, and therefore it has become firm and it will become non-tender. Now microscopically, it can be of three types. The presentation can be of three types microscopically. One is called follicular hyperplasia, other is called paracortical hyperplasia, and the other is called sinus histiocytosis. Okay, sinus histiocytosis. So we'll come to the three one by one. You can understand that from the name itself, you can understand what exactly is going to take place. Follicular hyperplasia, it will involve the follicles. Paracortical hyperplasia, follicles are not involved. The area between the follicles, that is the paracortex, is involved. And the other is the sinus histiocytosis, that is whatever is taking place, that is inside the sinus. So changes in three separate components will manifest as these three microscopic findings. And there is another, it can be mixed, that is all the areas are involved, even that can take place. Okay, so first is your follicular hyperplasia. What does that mean? It's very simple. That is the germinal centers. The germinal centers will be markedly enlarged. And these will be composed of mitotically active cells. Something is getting enlarged, there must be mitosis going on. So mitotically enlarged cells, and what cells? Obviously lymphocytes, and then there will be proliferation of phagocytosed cells containing phagocytosed material. Mitotically active lymphoid cells, phagocytic cells, all these giving rise to enlargement of the germinal center, and thereby enlargement of the follicle. So that is the follicular hyperplasia. In addition to that, what you will have is the parafollicular and medullary areas will also have more number of plasma cells, histiocytes, lymphocytes, eosinophils. So main pathology is taking place inside the follicular germinal center, but then the paracortical areas as well as the medulla, they are also having increased cellularity. And along with that, you will have the sinuses, involvement of the sinuses. The sinuses will have mononuclear phagocytic cells. So lymphatic sinuses will be filled with mononuclear phagocytic cells. So this point, that is the last thing, hyperplasia of mononuclear phagocytic cells, this is common to both follicular hyperplasia and paracortical hyperplasia. In follicular hyperplasia, again I am repeating, there will be hyperplasia of the follicles. Follicles have germinal centers. So if there is a hyperplasia, the germinal centers will be enlarged. Germinal centers will be having mitotically active lymphocytes, and it will also have your histiocytes. That is what is taking place in the follicular center. Aside from that, you will have the enlargement, that is increased cellularity in the paracortex as well as the medulla, along with the follicular hyperplasia. And the sinuses will be filled with histiocytes. These are the three features of follicular hyperplasia. You can see a picture. See how much the germinal centers have enlarged. This is the germinal center, expanded, this has expanded. But you can see, along with the expansion of the germinal center, the paracortical, these must be the paracortical areas, they are also showing some increased cellularity. So whenever you see such a picture, I have some better pictures later on. This is from your book. I have some other pictures I'll show later on. So this is your follicular hyperplasia. Next is what is paracortical. Paracortical, from the name it explains, it is very clear. Okay, so follicular hyperplasia will have increased number of B cells because B cells are in the follicles. Now paracortical hyperplasia, T cells. So this is, what is it? That increased number of T cell transformed immunoblasts. So the areas between the follicles are getting enlarged. So what will happen? If there is increase in the cellularity of the paracortical area, so the lymphoid follicles will be, what will happen? The enlarged paracortex will encroach on the lymphoid follicles and resulting in their effacement. I will show a picture. That is, the follicles or the germinal centers, they are not enlarging, but the paracortex is enlarging due to increased cellularity, and they are composed of T cell transformed immunoblasts. So what happens is the follicles will be encroached upon, and the follicles will be, their size will decrease. That is, the follicles will be effaced. Effaced means the normal structure will be lost. And along with these 2 points, the third point is, I have already told you, that is, there will be hyperplasia of the sinuses, that the sinuses will be filled with histiocytes. So look at this picture. See, these are the follicles. This was probably a primary follicle. This is a secondary follicle. But then what has happened is, all these areas, these have increased in cellularity, and you can hardly appreciate the other follicles. Like the other picture which I showed you, there should have been some follicle over here, but they have been lost. Why? Because this area has expanded so much that it has encroached upon the resting follicles, and some of them have been lost. So there is effacement of the follicular architecture. Normally you will find follicle formation in the cortex and nothing in the medulla. In between the follicles you will have paracortex. But here you can see the follicles are very decreased in number, and in between the follicles there is so much of increased cellularity. So there is effacement of the follicular architecture of the lymph node. The third is what is called sinus histiocytosis. The name itself shows that there must be something going on in the sinuses. So what is going on? The sinuses are dilated. Normally they have a caliber. It is getting enlarged. So sinuses are getting enlarged. And then what is happening? Inside the sinuses, they are filled with histiocytes. These sinuses, these are the sinuses. Now they are getting enlarged. You can see large dilated empty spaces inside the lymph node. So these are the sinuses getting enlarged. Sinuses getting enlarged, and the sinuses will be filled with histiocytes. Okay, so the sinuses will be filled with histiocytes. The histiocytes, what are the histiocytes? That is, they will engulf the inciting particulate matter by phagocytosis. So their cytoplasm will have the remnants of the ingested particle. So those are the histiocytes. So what will happen is, inside the sinuses you will have histiocytes, and the sinuses will be enlarged. So that is what we call as sinus histiocytosis. Now see, these pictures I have, just for comparison, I have put in these pictures. This is a normal lymph node. Why normal? Normal distribution of follicles, that is in the cortex, and this is the medulla. Normal distribution of follicles in the cortex, and this is the medulla. So you can find there is a clear demarcation between the cortex and the medulla. Now I have used the term effacement. What is effacement? That is, this demarcation is lost. That is called effacement. So in this picture, what you can see, this is follicular hyperplasia. So many follicles. This should be the normal number of follicles. But what you can see over here, there is follicle and follicle, full of follicles. So this is your follicular hyperplasia. What has happened over here? Although the picture is a little dark, so these are only the follicles. Only these areas are the follicles. 1, 2, 3, 4, 5, 6 maybe. The rest of it is completely dark. That is, there is expansion of the paracortical area. So the follicles are no more. So we have lost the differentiating features between the cortex and the medulla. So there has been effacement. There has been effacement. No normal demarcation between the cortex medulla can be appreciated. So there is an effacement. That's hyperplasia. Same thing as sinus histiocytosis. So these are the sinuses. This you can say, why aren't they looking empty? Because they are filled with histiocytes. Yeah, so as you can see, these are the dilated areas. Dilated areas, they're looking pink. They're not looking white. Why pink? Because they are filled with histiocytes. So if you look at a lymph node where you find so much of empty spaces, rather empty channels, and on higher power, under the microscope, if you find that those are filled with histiocytes, see, these are normal fats. This is the fat that has entered the lymph node anyhow. But then I am focusing on these areas, these dilated channels. These are your sinuses. They have become dilated and they are filled with histiocytes. If you observe, look at it carefully, you will find these are filled with histiocytes. So therefore, this is sinus histiocytosis. So is it clear the 3 distinct patterns of chronic non-specific lymphadenitis? Now what you're supposed to do, you may or you may not try to memorize these causes. That is the first, I think for your level, it is essential that you remember the first table as the causes of lymphadenopathy, where you can just enumerate all the causes. Here, depending upon which cause is presenting in which microscopic feature, I have divided the causes. So follicular hyperplasia, these things can result in follicular hyperplasia. That is reactive follicular hyperplasia, explosive follicular, for example, HIV, progressive transformation of germinal centers. All these causes were written in that table. Now I have divided that as per your morphological characteristics. So progressive transformation of germinal centers, few names, Castleman, rheumatoid, these, just try to remember the names, you at least 1 or 2. Don't go deep into what are individual diseases. So follicular hyperplasia, just like paracortical hyperplasia and sinus histiocytosis. Have you heard of this disease, Rosai-Dorfman? Okay. So if possible, just try to remember in follicular hyperplasia this name, Castleman's disease. And for paracortical, you can remember, if you have to remember only one cause, you say viral causes, EBV, CMV, all these will result in paracortical. And for your sinus histiocytosis, just if possible, remember this Rosai-Dorfman disease. Okay, so these are the various causes of lymphadenopathy based on their microscopic presentation. But even if you don't remember all these, you must remember the table that I showed you in the beginning. There you are supposed to divide the causes just into benign and lymphoproliferative. In benign, you will say infections, then you will say autoimmune, then you will say hypersensitivity, and then you will say others. In others, you will give all those other causes like amyloidosis, etc., storage diseases. Okay. In the malignant part, you will be in the lymphoproliferative part. You will again going to divide into benign, atypical, and clonal, and then the malignant. In the malignancy part, you are going to give Hodgkin's, non-Hodgkin's, and metastasis and your leukemia. You might get another question, that is how to classify lymphoma. That can be a separate question, but that will be taught to you by in the subsequent lectures. But in this case, you are just going to give the broad classification. And just for completion's sake, since the question was how do you differentiate, so clinical features and how do you diagnose. So clinical features, just like I said, that if it is an acute lymphadenopathy, then it will present as painful, swollen, red lymph nodes. And if it is a long-standing one, then what you will find is there will be the lymph nodes will no longer be tender, they might not be red, they will become firm, but in addition to that, you will have features of the underlying disease. If it is a long-standing, if it is a chronic non-specific lymphadenitis, so there must be some underlying cause. So you will have features of the underlying cause, which is very important. The most important thing is, this is very important, is weight loss. Fever, weight loss, malaise, loss of appetite. For example, a TB lymphadenitis. So it will have symptoms of TB. For example, it is a case of Hodgkin's lymphoma. So it will be presenting as Hodgkin's lymphoma, where there will be weight loss, evening rise of temperature. You will be taught about ANOI, staging, and etc. B symptoms, etc. will be taught when Hodgkin's lymphoma will be taught to you. So my point is that if it is a short duration acute lymphadenitis, then it will be just painful, tender, and enlarged lymph nodes. But if it is a long-standing case, then the symptoms will be that of the underlying disease. So if you can remember a few symptoms of some of the diseases, you can just write those. And the last part is, how do you diagnose? The diagnosis is mostly by histopathological examination. That is, lymphadenopathy, the cause of lymphadenopathy, to know exact cause, you have to go for histopathology. So histopathology comes first, and other causes, like clinically you will check what are the other symptoms. Laboratory and imaging studies. What is laboratory? Laboratory is mostly your microbiological investigation. For example, you are having a TB, lymph nodes from due to enlarged TB. So then you will go for Mantoux test, or like you will take a sample and then send for PCR, TB PCR, just like that. So that is mostly the laboratory. Laboratory, it involves, or suppose there's a case of you are suspecting a Hodgkin's, non-Hodgkin's lymphoma, so you will go for a peripheral smear. You will see that there is an increase in number of lymphocytes. So those are the laboratory investigations. And finally, as you can see, imaging. Imaging will show you what are the lymph nodes that are enlarged. For example, you can palpate lymph nodes which are either in the neck or in the inguinal region, but say in the retroperitoneal or in your mesenteric lymph nodes, if they are present, only imaging can detect them. And then you will have guided biopsy from those areas, and then you can say whether these lymph nodes are due to what kind of a pathology the lymph nodes have enlarged. Okay, so that is all. That is all about today's lecture. Just remember, there is an exam question. Pathogenesis and pathology of tuberculous lymphadenitis. This is what I have taught in my last lecture. Exact same thing. Tuberculosis I have taught. In tuberculosis, I had discussed about tuberculous lymphadenitis. The pathogenesis and pathology is the exact same thing that I have told you. I had showed you in a tabular form. I think I had discussed in detail how regarding the evolution of a granuloma. Very few people were there. Did anybody remember?